Yes, Dr. Shen, we are ready to have you on. Uh,
Okay, sure.
as you are aware, this is, of course, you have been one of the mentors for the Society for Maternal Fetal Medicine for India. And we are spreading our wings. Today, we are going to have Kerala and Mumbai joining us for the program. Last
Oh,
time, we had
wonderful.
Ahmedabad and Bahrain. So, this is our first annual day.
Wonderful.
So this is our first annual day, and we are very happy that we are starting this kind of an international coordination with you because, as I said, you have been one of the guiding forces for the society. Okay, I
It's
think
been
we
my
are ready
pleasure.
to
Yeah.
we are ready to start. You could please go ahead.
Okay.
Yeah, introduction, Sushma or Revti.
Good morning, Dr. Chen. I
Good
would be
morning.
introducing you to the crowd. Dr. Kenneth Chen is the Division and Fellowship Director of Obstetric and Consultative Medicine, Co-Director of Integrated Program for High-Risk Pregnancy, Staff Endocrinologist, Women and Infants Hospital of Rhode Island, Providence, Rhode Island, USA. He's the Assistant Professor of Medicine, Assistant Professor of Obstetrics and Gynecology, Alpert Medical School of Brown University, and he's also the president-elect of the International Society of Obstetric Medicine. So we have Dr. Kenneth Chen here, and most importantly, he was the one who launched our society last year globally at the ISOM meet Cape Town. So we welcome Dr. Shen for the first annual meet. We also have Idapal from Kerala joining in. We can see the audience there. I mean, it's a little early here, it's a little late there at Rhode Island, so we're trying to get it together. So
No, it's okay. It's quite okay.
so leave the
So,
stage
thank you.
to Dr. Shen.
Yeah. Okay. Well, thank you all very much for inviting me to do this. It gives me great pleasure to be part of your, your first national meeting. And I will start my talk in a minute, but I was wondering whether I could, just use just 1 minute of time just to give a plug for this coming year's ISOM meeting. I really enjoyed having you guys on board at the meeting virtually last year, and our meeting is this coming year in October. And in fact, if it's okay with you, I'm going to email you some more details, and if you would like to potentially either come in person or do, or maybe participate in the meeting virtually, please let me know. The dates are October the 6th and the 7th of this year, and hopefully I may get to see some of you in person as well. I've been asked to talk a bit about MODY and pregnancy, and the backdrop of this is that MODY stands for mature onset of diabetes of the young, and the reason this topic gives me great interest is that like in my mind, I think there are quite a lot of these cases which are undiagnosed, generally, and especially even in pregnancy. And so I want to kind of just outline the main points relating to this, so that you could all, think about the possibility of patients of this, as you see them in pregnancy, because it could potentially have fetal effects. So just to begin, I do not have any disclosures, and I will not be discussing any off-label use of medications. And I acknowledge a few people here who have helped me put this topic together. And the first person is Dr. Matthew Esposito, who works at my hospital, who is a maternal fetal medicine specialist, and I collaborated with him quite a lot in managing these patients. Dr. Camille Poe is a graduating endocrine fellow who works at the Massachusetts General Hospital in Boston, and this has actually been one of her areas of interest as well. And I collaborate regularly with her as well. And the last person is actually Dr. Chris Stavatinsky, who's an MD PhD candidate from Germany. And when he did an elective with me a couple of years ago, he actually kind of helped me look at this data and put everything together as well. So I want to acknowledge all three of these individuals. So just to begin with, I'd like to just start off by a very simple case presentation. And this case relates to a 28-year-old lady who I came across a couple of years ago, who was gravid to Para 1001, who was 8 weeks gestation, who was referred to me by her OBGYN due to an antenatal lab value of A1C level of 6.3%. And the history with her is that she had a pregnancy. Her first pregnancy happened 3 years ago in New York City, which is about 4 hours drive away from where I work. And she tells me that this was complicated by gestational diabetes, in that she required small doses of insulin therapy towards the end of the pregnancy. Now, she was asked to attend a postpartum glucose tolerance test, a couple of months later, but unfortunately she didn't do this. She doesn't have any other significant past medical history, and she's on no other regular medications. Of interest is the fact that she has a fairly strong family history of diabetes. She tells me that her father was diagnosed with mild diabetes through routine screening aged in his early 40s. And on the same side of the family, her paternal grandfather also had adult onset diabetes, though she doesn't know too much details about her. And it's interesting to note that neither the father nor the paternal grandfather neither of them were overweight. Like both the BMIs were well below 25 throughout their whole lives. And when I examined this lady, her blood pressure, she was normal tensive at 110 on 70, and her BMI, interestingly, was only 21. Like she, was actually definitely not overweight. And she was very well appearing, and she had no clinical signs of acne, hirsutism, acanthosis nigricans, any pigmented stree or muscle weakness. Like she basically was completely normal with no physical findings of interest. So I could ask you all to tell me what you think is going on, but I think you guys already know what the topic of today is. So I'm going to move right along to just kind of discuss, this table, which lists the common and I guess the less common causes of diabetes. So on the left-hand side, as you can see, that the common types are obviously gestational diabetes would be the most common. And currently in the US, the incidence with gestational diabetes is about basically on 10%. Of all pregnant women. So type 2 diabetes, type 1 diabetes, obviously very common. And over here, type 2 is responsible for 90 to 95% of diabetes, and type 1 is responsible for the other 5 to 10%. And occasionally we come across people who may have drug-induced diabetes, like particularly people who are on medium-term or long-term steroids. Now, on the right-hand side, we have the less common causes, but these are things that we often think about when with patients who may perhaps we don't expect might have either type 1 or type 2 diabetes. So people can get pancreatic sufficiency. So as an example, if they have chronic pancreatitis, iron deposition from hemochromatosis, or of course cystic fibrosis, like these can lead to diabetes as well. People who have endocrinopathies, particularly acromegaly or Cushing's syndrome, they certainly could present with diabetes. And then lastly, I've listed there, like there could be genetic causes of diabetes, and MODY, which is, again stands for mature onset diabetes of the young, would be a relatively common type of genetic form of diabetes. So I'm going to kind of discuss this in a little bit more detail. So I'm going to now talk about, what is MODY, like in terms of the genetic causes, when to suspect it, and how to diagnose it. I'm going to talk a bit about the complications of MODY as well as the management of MODY, and especially I'm going to concentrate on the management of MODY in the context of pregnancy. Okay, so just bear with me with these next few diagrams, because I want to just kind of remind you all about the physiology of insulin signaling and insulin secretion through the pancreatic beta cells. So basically, as you can see up here, glucose gets transported into the beta cell through the glucose transporters. So typically, the most common one is GLUT4. Basically through phosphorylation, glycolysis occurs, and basically the mitochondria releases ATP, and then the ATP kind of comes up through this channel, the ATP sensitive potassium channel, which then leads to calcium depolarization, and then the calcium gets retaken up into the pancreatic beta cell through the voltage dependent calcium channel. And in the meantime, the endoplasmic reticulum over here, which basically with the calcium influx back into the cell, this actually leads to the endoplasmic reticulum in helping insulin-containing granules to be secreted through by the endoplasmic reticulum, and that insulin secretion then occurs. Insulin release and insulin secretion then occurs. So the next slide is. So in summary, mature onset diabetes of the young, it's generally due to single mutations in beta cell genes. And bear in mind that this is purely an insulin secretion defect and there's no insulin resistance, okay? Of course, patients may have additional insulin resistance, but the actual syndrome itself, it's mainly insulin secretion, it's only an insulin secretion defect. And statistics show that in the US, about 2 to 5% of diabetes is actually MODY. And actually, there was a paper that was published back in 2010 which shows that more than 80% of MODY cases are misdiagnosed as either type 2 or type 1 diabetes. The mode of inheritance is autosomal dominant. And bear in mind that there are never any autoantibodies with these patients, okay? So, and I'll discuss how this is important in helping us diagnose differentiating MODY from type 1 diabetes later on. The cause and the management depends on the actual genetic mutation, and I'll be discussing the 6 types very shortly. And as I've alluded to, a lot of these patients get misdiagnosed as either type 1 or type 2 diabetes. So I've circled here the main kind of gene defects that kind of happen, and glucose kinase is responsible for type 2 MODY, and then HNF4 alpha, HNF1 alpha are responsible for type 1 and type 3 respectively, and then these other 3 at the bottom are a lot rarer, okay? And so when you get an issue with these genes, then as you can see here, then they're basically, this causes an effect in a defect in insulin secretion. Okay, so let me go through the 6 different types of MODY, and I'm kind of going to just generally concentrate on the key points. So MODY type 1 is when there's a defect in the hepatocyte nuclear factor 4 alpha, or otherwise known as HNF4 alpha. And it's responsible for about 10% of MODY cases. And the clinical features are, of course, people, they get diabetes, and they usually get a lot of macrovascular and microvascular complications. And basically these people, because of the abnormal regulation of the gene transcription, it leads to an issue with insulin secretion. And generally, the treatment is you use sulfonylureas or insulin, okay? Because the sulfonylureas then leads to, which actually enhances insulin secretion, helps the patients overcome this kind of defect in the transcription factor. And bear in mind that people with HNF4 alpha defects, they have an increased incidence of colorectal and liver cancer, okay? So I've circled HNF4 alpha here, okay? Now, MODY type 2, and I'll be discussing this in a lot more detail later on, is when there's a defect in the GCK, the glucose kinase gene. So there's a defect in the phosphorylation of glucose to glucose 6-phosphate, okay? And this is responsible for about 30% of MODY cases. And the clinical features are people are usually quite asymptomatic, but if they were to have a 2-hour glucose trans test, they're typically noted to have an impaired fasting glucose and or impaired glucose tolerance. Okay, so generally they're asymptomatic, but they'll have abnormal kind of values when you do a 2-hour glucose trans test. And the molecular defect is, like I said, there's a defect in the sensitivity of beta cells to glucose due to reduced glucose phosphorylation. And there's also defect in the hepatic storage of glucose as glycogen. So these people, they tend to kind of have an increase in gluconeogenesis, particularly during the night. And the treatment really for these patients is diet and exercise. Of course, as the condition advances and they develop insulin resistance, we may need to start them on other treatment, but by and large, we just tell people to kind of just lifestyle changes of diet and exercise on it. And so just again, just the gene defect, so there's a issue with the phosphorylation of glucose to glucose 6-phosphate, which then impairs this impairs the downstream reaction from the ATP being able to be released. And then just bear in mind that the GCK mutation basically causes a glucostat reset. Okay, so these people kind of are used to living at a high glucose level, and they don't usually kind of typically get any issues until the glucose level really does rise quite significantly. Okay, so like I said, I'll be concentrating on this a bit more later on with regards to pregnancy. And this graph actually kind of just illustrates what happens with MODY type 2. Like the bottom line here, sorry, the top line here relates to patients which are normal, and the bottom line here relates to patients which have the defect in glucokinase 2. And as you can see here, for normal people, when they reach a plasma glucose of 10 millimoles per liter, about 50%, basically, the glucose phosphorylation capacity reaches about 50%. But for this same person who's got MODY, when they reach a glucose level of 10 millimoles per liter, only about 35% capacity is reached. So in summary, these people need to get to quite a high level before the appropriate glucose phosphorylation capacity is reached, and hence the glucose level stays kind of a bit higher, and I guess the insulin release doesn't happen until they reach quite a significantly high glucose level. And so the important thing to note with MODY2 is that often women with asymptomatic hypoglycemia secondary to GCK MODY won't present until they basically get a oral glucose tolerance test in pregnancy. Okay, so this is a very key thing to note, that often these people won't get diagnosed, but they may present for the very first time when you may be looking after these people for a positive oral glucose tolerance test. Okay, now MODY type 3 is a defect in hepatocyte nuclear factor 1 alpha, HNF1 alpha, and basically this is responsible for the majority of MODY cases, more than about 55%. And this behaves very similarly to MODY type 1. Okay, so I won't dwell too long on this, other than the fact that a lot of these people get a lot of diabetic macrovascular and microvascular complications, and they get the and usually the treatment is sulfonylureas or insulin. Okay, and again, HN1 alpha I've highlighted here. Okay, so the three other types are very rare. Between the three of them, the types 4, 5, and 6 are only responsible for 5%, and the MODY type 4 is due to a defect in the IPF1 gene. MODY 5 is due to HNF1 alpha beta, and MODY 6 is due to NDF1. Okay, and generally speaking, I think these are all kind of very rare, and the key things to note are that with type 5, often they get the renal cysts, and they actually get chronic renal impairment quite a lot earlier, so just kind of keep that in mind. Okay, so I'm going to now kind of just spend the next couple of slides just summarizing the diagnosis and overall management of MODY in terms of the principles. So of the history of presenting illness, it's important to kind of certainly find out what the age of diagnosis is, whether there's any family history of any of these things I talked about, including things like renal cystic disease, and just generally, what they've been treated with in the past, or specifically if they have a strong family history of this, whether they know what their family members were treated with. Now, clinical features, if they have features of insulin resistance, I think you're more likely looking at type 2 diabetes. If they're quite overweight, then of course, I think type 2 will be more, it could still certainly be MODY, but you'd be thinking that type 2 will be a lot more likely. And certainly you want to see whether there's any other endocrine features, because like I said, occasionally with things like acromegaly or Cushing syndrome, you could get other endocrine features as well. Okay. Now, the laboratory level, if they have a very low or I guess 0 C-peptide level, then you would be more likely looking at type 1 diabetes. If they have autoantibodies, then I think again that you're looking at type 1 diabetes. And bear in mind that people with HNF1 alpha, they usually have an elevated highly sensitive C-reactive protein, so this is something that may be able to help you as well. But the bottom line is that, like, if you're suspecting somebody of Modi, you need to do genetic testing. And usually, the labs, if you're asking for Modi, the labs would actually sequence for you the most commonly affected genes, like the HNF4 alpha, HNF1 alpha, and the GCK genes. They'll kind of do it all in one hit for you. And indeed, if you actually do diagnose somebody of Modi, the University of Chicago actually has a Modi registry, which which may be helpful. Occasionally in the U.S., like there's some cases where the insurance companies actually don't cover the people for genetic testing, and I've actually gone to the University of Chicago to help me do it, because they are interested in collecting these patients, and they've done it for me free of charge. So basically, when you suspect Modi, and these are my personal tips. I think if you feel like there's somebody with type 1 diabetes, but in the picture don't kind of completely fit, these are the additional features which may help you suspect Modi. Like, so if people, occasionally I come across people with type 1 diabetes, but then even if they're not have any insulin therapy for quite a long period of time, they don't tend to progress to ketoacidosis. And so those people, I'll be very strongly suspecting Modi type 1 or type 3, okay? Because, if people do have true type 1 diabetes, there's no way that they're not going to get ketoacidosis if you don't give them insulin. As I've alluded to, people, if they don't have any autoantibodies, they have negative kind of anti-GAD, anti-IA2 antibodies, and they actually have a detectable C-peptide, then again, you wonder whether they may have Modi instead of type 1 diabetes. And if they have a very strong family history for diabetes, as in like it tends to just affect a number of multi-generational family members, and it keeps getting passed down, then again you wonder whether it might be Modi, because remember I said that Modi is autosomally dominant, inherited. Now, when you consider in patients who and you're wondering whether they may have type 2 diabetes or not, like, so if they kind of have a young onset of less than 35 years, though I do want to say that with the increasing epidemic of obesity, like, we are seeing a lot more type 2 diabetics who are a lot younger, but let's just say that this is somebody who's not particularly profoundly overweight or obese, and you consider it when they're kind of a bit on the younger side. And then on examination, they don't have any features of insulin resistance. I do want to say that people who I see who've got type 2 diabetes, they usually would have like things like acanthosis nigricans, and I want to kind of just highlight that acanthosis nigricans, please actually examine people's knuckles on their hands when you see them, because often you may not see, it's a very simple thing to do, and I find that people who have profound insulin resistance, they often have pigmented knuckles on their hands. Okay, so just keep that in mind, and if they have a very marked sensitivity to sulfonylureas, like as in you give them a very low dose and they have a very marked sensitivity, consider these people as having Modi, type 1 or type 3 instead of type 2 diabetes. Okay. Because usually for people with type 2 diabetes, they should respond very well to metformin, but occasionally I come across people who they don't really respond well to metformin. Doesn't really do anything for them, but then you start giving them a very low dose of sulfonylurea, and then they respond very well. Like, keep in mind whether they may have Modi or not. So in summary, Modi type 2 of GCK, as I've said, normally we use diet and exercise, but with Modi type 1 and type 3, we use start of low dose sulfonylureas, and then we often have to step up the doses, and eventually most people will need to get onto insulin therapy. Okay. Now, what about complications of Modi? So this paper, just over 20 years ago, kind of summarized the incidence of complications relating to people with Modi type 3, which is the blue lines. Modi type 2 is composes the red lines, and the green line composes people with type 2 diabetes. And as you can see here, interestingly, people with Modi type 3, they have a much higher incidence of proteinuria compared to the type 2 diabetes and GCK. And similarly with retinopathy. Okay, so people with proteinuria and retinopathy, the much higher incidence of Modi type 3 and type 2 diabetes compared to the GCK. But interestingly, with neuropathy, the incidence of this was not particularly that much different between Modi type 3, type 2, and type 2 diabetes. So that's kind of quite interesting. So in summary, if you see somebody, again, with with who you think has type 2 diabetes, and they get early onset, relatively, I guess, like proteinuria nephropathy, again, kind of consider whether they may have type 1 or type 3 Modi instead. Okay, and interestingly, of GCK, that they actually have a relatively high incidence of neuropathy compared to just the baseline type 2 diabetics as well. Okay, so this slide kind of again just summarizes the incidence of the various conditions. And blue this time is control, red is GCK, and green is type 2 diabetes. Okay, so as you can see here, by and large, the controls and the GCK were not that much different with the microalbuminuria. Retinopathy is high in GCK, and same, but bear in mind that actually, interestingly, macrovascular disease was actually even lower than the control group. So it's mainly macrovascular, complications that you have to mainly be worried about. Okay, so what are the considerations of pregnancy? This paper from 2014 kind of estimates what the Modi prevalence is within specific diabetic populations, and so keep in mind that with gestational diabetes, the incidence is thought to be about 1%. So one out of 100 women with gestational diabetes will have Modi. Okay, and this is kind of fairly similar to the incidence of pediatric diabetics, or I guess type 1 diabetics with the onset of less than 45 years old. But with type 2 diabetes onset of less than 45 years old, it's actually 4%. Okay, so again, 1 in 25 patients who you think may have type 2 diabetes actually have Modi. Okay, but the key one for all of you to kind of recognize is that, like I said, one out of 100 gestational diabetic will actually have Modi. Now, I guess really the only large cohort which has been studied to date in relation to Modi is the Atlantic Diabetes and Pregnancy cohort, and most of these patients were actually from the United Kingdom or the United States of America, and when you compare the people with GCK Modi compared to the people with gestational diabetes, it was interesting that the mean age of people with GCK Modi were a few years younger than the people with gestational diabetes, which is probably not unexpected because the incidence of gestational diabetes would increase as you get older. The BMI is quite a lot lower. Okay, so these people actually, the mean BMI was actually within the normal range of 23.9 as compared to the GDM mean BMI, which is actually more than 31, which is more than 30. Okay. And I'll put the units here in milligrams per deciliter, but the mean kind of fasting glucose for the GCK Modi group were quite a bit higher compared to the GDM group. So for GDM group, this is 94 is about 5.2, and for the people with GCK Modi, this is actually above 6. Okay, and for the 2-hour oral glucose tolerance test, the 2-hour readings were again higher compared to for the GCK Modi group compared to the GDM group. Okay, all right. So in terms of just distinguishing GCK Modi from GDM, this same paper kind of concluded that if we set if we want to kind of estimate how many people with elevated fasting glucose, 99 is actually 5.5 millimoles per liter. Like if we want to estimate how many people have an elevated fasting glucose of more than 5.5, but who have actually whose BMI is less than 21, all of these people are actually going to actually have Modi. You only need to test one patient to get back to get a result of GCK Modi, but only 20% of these cases will be identified. Okay, so in summary, when you set the BMI as less than 21 and they have elevated fasting glucose of 5.5, all of these people are actually going to have Modi, but you only pick up 20% of these cases. If you move down to setting the BMI as less than 25 and then the fasting glucose of more than 5.5, you need to test 2.7 women before you pick up a case of GCK Modi. And then this time by then, with this threshold, you pick up 68% of cases. If you set the BMI as less than 30, and the fasting glucose of more than 5.5 millimoles per liter, you need to test 6.5 women before you pick up one case of GCK Modi. And then by then you're going to pick up 82% of cases. So in summary, if you see somebody who has a very low BMI, definitely be thinking about GCK Modi, okay? Like, because we really, when you said it, this study showed that like pretty much all these patients actually have this condition. Now, Modi in pregnancy. So basically, like if you have somebody who's got Modi type 1 and type 3, you basically treat them exactly the same as you would of a type 2 diabetic, okay? Like, you could potentially start them on sulfonylureas, but usually when they're pregnant, you would just go straight into insulin therapy. And in fact, recent ACOG guidelines actually suggest that, people shouldn't really even be thinking about using sulfonylureas now. Like, they've actually changed their stance, just as a digression. Like, it used to be that they recommend that people can be on insulin or sulfonylureas, but they've actually recently changed their stance that if people who's got gestational diabetes, like, you would go straight to insulin, or you consider metformin. So if you do have people who've got Modi type 1 and type 3, you could certainly, if you wish, continue on low dose sulfonylureas, but almost all the time you should really just think about switching them to insulin therapy. Now, if the woman's got Modi type 2, GCK, you need to strongly consider whether the fetus is actually also got the glucose kinase gene defect, or whether they don't have the gene defect, because as I'll discuss, this has major implications for the management of the fetus. So Hattersley, back in 1998, actually published a paper which, and he basically kind of followed various women who's got Modi type 2, and he actually did genetic testing, intrauterine testing on the fetus to see whether the fetus has also got GCK or not. And as you can see it, there's 4 different groups here, okay? So he had a control group where the mother and fetus were both negative, and basically he discovered that basically the mean birth weight was about normal, like about sort of 49th percentile. Now, if the mother and the fetus both have GCK, interestingly, again, the birth weight's kind of very close to the 50th percentile. It's actually about 53rd percentile. What he did find, curiously, is that if the mother's positive and the fetus is negative, okay, the birth weights of these children tend to be higher, and the explanation for this is this: the fetus doesn't have GCK, so the fetus would like to be in a normal glycemic environment. Remember what I said earlier on, that people with GCK, they have a high glucostat reset, right? So the fetus doesn't have that glucostat reset, so the fetus would like to be at a lower level, but because the mother is got GCK, the mother tends to be a bit higher, and so this does lead to kind of a elevated birth weight percentile, and the incidence of macrosomia is certainly increased. Now, interestingly, if the mother is negative but the fetus is positive, okay, so the mother is negative, but the fetus would like to be at a high, would normally be living in a higher glucostat range. Curiously, the babies would tend to be a bit on the smaller side, okay? So this is where it's important to have an idea of what the fetal, like if we know that the mother is positive, it's important to know whether the fetus is positive or negative, okay? Because this has strong implications as to how you manage them during the pregnancy. So I'm going to move on to another study that was published 2009, and again this showed very similar kind of results to the previous paper by Hattersley, like where again the mothers who were positive of a negative fetus had kind of elevated had an elevated birth weight percentile, and the mother who's negative of a positive fetus had a significantly lower birth weight mean percentile. Okay. So now, what do we do in terms of treatment? So basically, that same paper in 2009 actually looked at what happens when you treat mothers with Modi type 2 whose babies are negative, okay? And basically, there was a control group where they used diet, and then another group where they used insulin, and basically, as you can see here, the main differences were that actually there probably wasn't too much difference other than the women who were treated with insulin, the babies were delivered about a week earlier. and the birth rates were kind of I guess comparable. Like when you take into effect that these babies were born a bit early, the birth rates are probably comparable. And interestingly, the mean percentile birth rate were not that much different. And so this means that actually, in summary, if the mothers are positive and the babies are negative, it doesn't really matter that much whether you use diet or insulin. So, but it's more important to just make sure that they're being treated to target. Okay. All right. So the actual mode, in summary, doesn't matter all that much, and it's more important to look at the actual targets. So I'm going to move on to this same author who actually published a case report a few years before that study, and again is a mother with the type 2 MODY who were treated with intensive insulin therapy to normal glycemia during 2 consecutive pregnancies, and the first child actually had the positive, was positive for GCK gene defect, and the second child was negative. And look at this, like if you actually overtreat the first woman, like remember how I said that child is actually positive, then you actually want to let them run their glucose levels a little bit higher. When you actually kind of treat them intensively, they actually became very small, like they actually had a bit of growth restriction. Whereas if you treat them, whereas when they were negative, like this actually kept that baby kind of about 50 percentile. So okay, so look at what a big difference like this makes whether the baby has the mutation or not. Okay, so what about when you treat the mothers with MODY and then the babies also have GCK positivity? Like, so this leads on to that question. So this so another study showed basically in this case, like when you allocated into diet versus insulin. Interestingly, the people with diet actually kind of did seem to do better. The babies kind of were more, about a 51st percentile birth weight, whereas the ones who you treated with insulin, the birth weight were a bit lower, and the corrected birth rates were a bit lower, and the mean percentile birth weight was a little bit lower as well. Okay, so just keep that in mind. So I guess in the final 5 or 10 minutes, I want to kind of just open up for discussion. Like, in summary, these are kind of the clinical dilemmas that, in my mind, we may be faced with if we're dealing with a mother with MODY type 2. The first question is, what is the role of amniocentesis or chorionic villus sampling in mothers with known GCK mutation? How often should we be doing growth ultrasounds in the setting of an unknown fetal genotype? And when should we commence empiric insulin therapy in a setting of an unknown fetal genotype? And I really would like to open this up for discussion. I would like to, like me and my colleagues at my institution have basically put forward this suggested algorithm, but I definitely want to open up for discussion for all of you. So in summary, if we know for a fact that the fetus is also positive for GCK, I think we really don't need to give them any specific treatment, okay? Other than just asking the woman to kind of just eat healthily and just do some regular exercise. I guess in summary, they don't really need to do anything, but which is what you normally ask them to do anyway if you want them to have a healthy pregnancy. So if their GCK is positive, no treatment. If the GCK is negative, then I think it's best to just treat them with insulin therapy and deliver them at 39 weeks. So I think basically, you would do what you would normally do if somebody has got gestational diabetes or even, I guess, type 2 diabetes, okay? Like, because these fetuses, they want to be in a normal glucose range and they don't like kind of being exposed to the higher levels that you get when the mother is positive. Now, what happens if the fetal genotype is unknown, which would be most of the cases? Me and my colleagues have decided that, if amniocentesis or CVS is being pursued for another reason, I think, and we know that a mother's got GCK positivity, we may as well kind of test the fetus for GCK as well, if, like I said, we have to do an amnio or CVS for any other reason. Now, if there's no other reason to do an amnio or CVS, then I think, the risk of the amnio and CVS is not without the risk. So if we don't end up doing it, we feel like it's okay to kind of sit tight. And if the status remains unknown, then we don't want to give them insulin therapy. And me and my colleagues have decided that the best thing to do is to do 2 weekly ultrasounds for 26 weeks. so that if we suddenly notice a big change in the fetal growth rate, then that might actually give us the answer that perhaps the fetus is actually GCK negative, and then we could think about giving them insulin therapy. Okay, and then we've also discussed that, like, if if the abdominal circumference suddenly becomes more than 75th percentile, and then again we should start thinking about putting them on a little bit of insulin therapy, and indeed plan to deliver them at 39 weeks. So, like I said, this is just our personal algorithm that we use at our institution, and we certainly welcome any suggestions, and because basically no studies have actually been kind of done to look at the best practice for this, and at this point in time, I'm pretty sure that that's my last slide. So I'd like to just open up the rest of the 10 minutes I have with you for any questions or comments from the audience, and I'll be happy to discuss anything.
Well, thank you, Dr. Shen. The paper is open for discussion. I think we give first chance. We give first chance to our Kerala colleagues. Any question from Kerala? Do we have any questions or comments from Kerala?
No, sir.
No, okay. Yeah, we have Dr. Revati asking a question.
Dr. Shen, after listening to this very interesting lecture, I feel we have at least about 10 to 15% of the patients who present to us with gestational diabetes, and they're necessarily moody. I mean, could be higher than what is probably quoted in literature, because we've really not counted them. But most of these patients also have a very high fasting blood sugars. I mean, their GTT2R value is normal. So is that a clue that they are moody, and probably we have to loosen the kind of treatment protocols that we have? Because we may not be doing genetic testing in them to find out exactly whether they're going to be GCK positive. But we do have to probably avert problems of hypoglycemia in the mother and fetal growth restriction in the fetus in case they are moody and GCK positive. That's the worry.
Yeah, so basically getting back to this big cohort, as you can see there, both the GCK and the GDM had elevated glucose levels, but particularly when you look at the fasting levels, like the fasting level was quite a bit higher for the GCK population. So in summary, if you have somebody who's not particularly overweight, and you're quite correct, and they have a relatively much higher fasting glucose compared to the 2 hour, definitely be thinking of these people. And I agree with you. I think it's hard. I think it's not so much that you necessarily want to over intervene, but I guess it's more just keep in mind with what I've said, that if you think somebody may have MODY, then you just keep an open mind that you may not necessarily just want to go down the route that you would normally go with a gestational diabetic, because again, if it turns out that the baby's also got it and you overdo it, then you might actually be, I guess, potentially doing the fetus a bit of disservice. So I guess, in summary, the main thing I wanted to point out is just keep in mind all these clinical factors, and just keep a very open mind that you could be dealing with MODY, and like I said, the key things are that if somebody's actually relatively not overweight and they have a higher fasting glucose level, definitely keep that in mind for sure. And again, a very strong family history. If they tell you that this has been running in a lot of previous generations. And bear in mind this one other thing, of course, of the increasing incidence of obesity, we are seeing a lot more people who get glucose intolerance from being overweight and obese. But bear in mind that if they give you a history that the family members have been diabetic for quite a few generations, it's probably not so likely that back a few even 3 or 4 generations ago, that people will be particularly overweight. So again, just keep all that in mind.
So what would be the surveillance protocol, Dr. Shen? I mean, the postprandials are going to be normal, the fasting is going to be slightly high. So you're just going to counsel them on lifestyle modifications is my question. Yeah,
I think so. In summary, mainly just make sure that they're doing all the things they would normally do for any other pregnancy, and I think that will be the main thing. I mean, fortunately, these people typically don't need to be started on on oral medications that early. So I think the key thing is just make sure that they're keeping themselves in shape. And actually, one of the key things is that they actually don't put on weight. Remember what I said, like when they first get this, they don't actually have any insulin resistance, okay? So where they run into problems is actually when they eventually develop insulin resistance is actually when they run into problems. So just make sure that they keep themselves at a good, normal, I guess, healthy weight, that they, they don't, but basically the reason that you want them to do diet and exercise is that they don't actually get insulin resistance, which will then end up causing additional problems. I think in summary, just tell them to lead a healthy lifestyle so they don't get that, and during the pregnancy, again, the same thing, like that they try not to put on too much additional weight, because if they do put on a lot of additional weight, then they become insulin resistant, and then that's when they get other issues. And in terms of the target, getting back to your question, with the targets, it's not going to be possible for them to necessarily be within the normal range that we would expect other people to be. But I guess so. Normally, I would be happy to kind of let them, I guess in summary, if they were to have a glucose tolerance test, make sure that whatever levels that they got in the 2-hour glucose tolerance test, they don't subsequently exceed that. Okay, so as an example, if in the oral glucose tolerance test the fasting level was 6, make sure that they don't get any higher than 6. That would be my very general guide as to how you would, in terms of what targets you would use to treat them. Like, look at what the 2-hour glucose tolerance test was and make sure that they don't actually exceed that. Okay.
Is there a difference between persistence of diabetes in the postpartum period between Modi versus real GDM?
Yes. Okay. So, like I said, if they develop insulin resistance, then it's pretty much the same as GDM. If they don't end up getting any additional insulin resistance after they go through the pregnancy, then the incidence should actually be lower. Okay. So that's why I was saying, make sure that they keep healthy and they don't put on too much additional weight. And actually, what you also want to do is make sure these people get back to the pre-pregnancy weight reasonably as quickly as possible, because if they end up putting on weight and they don't lose the weight, then they will get insulin resistance, and then they're going to run into trouble in the medium to long term.
All right, coming to the protocol for fetal genotype unknown, that's the kind of patients we see most of the time. Now, if you're going to commence insulin therapy only after abdominal circumference is greater than 75th centile, aren't we disturbing the fetal programming? Maybe the insulin started earlier, could have been better?
Yeah, this is a tough question. So, look, this is very, very tough. And like I said, me and my colleagues have debated a lot about this. I agree with you. This is very tough. I think a lot of it will depend on the rate of change. And that's the reason that we're offering, that me and my colleagues are offering so many ultrasounds. Every 2 weeks, a bit excessive, but because what you're looking for is a relatively, sudden increase in the percentile. So if they started off, I think in summary, what you want to do is be tracking what happens to the growth, percentile growth over at the abdominal circumference over a period of time. And it's more that, if you see it creeping up, and then if they start off at being 50th percentile, and then they creep up, and then ultimately they reach 75th, and it's more that at that time we definitely want to start treating them. But sometimes the problem is, as you know, with the ultrasounds, it's hard to know whether some of these increases are kind of whether they're definitely the real thing or whether it's just artifactual, right? So I think, we've discussed this at a lot of detail, and that's just very roughly what we decided that we're going to do. And I agree with you that technically that could be getting a little bit late in terms of the fetal programming. But we've also seen cases where sometimes, as you know, the measurements go up, and then somehow when you do it again a couple of weeks later, it kind of then stabilizes, and you don't know whether, So yeah, in summary, I definitely know what you're saying, but we may very well have to change this down the track once we get more patients. But with the patient cohorts that we've looked at, so far, we decided just to very arbitrarily kind of. And I'll be, like I said, there's not much data around even internationally with this, if all of you actually happen to certainly be seeing more of these patients and you want to think about collaborating for international study, please let us know.
Sure.
Yeah.
I would like to know, since there is no insulin resistance in Modi, if a patient doesn't have a history of PCOS pre-pregnancy, would you exclude Modi in such patients who have a history of PCOS and develop GDM later on?
Okay, good point. Okay, so yes, so okay, all right, that's a very good point. So it could be that for these people they may have coexistent insulin resistance or PCOS. Look, that is certainly that is certainly very possible. But I think on balance, if you were to see somebody with PCOS, usually the baseline BMI would be a little bit higher than the average kind of group that you see of Modi type 2. So I think from my perspective, I would probably just stick with assuming that they've got PCOS and insulin resistance, and then it's only if things don't kind of fit after that, then you can consider kind of maybe doing the gene testing for Modi type 2. I think this is the population more. That I guess this population are mainly targeting at the ones who are kind of definitely not overweight. If anything, sometimes they may be, and then you just can't explain why they're getting these kind of elevated levels.
See,
But
now
I think in
don't
summary, I think if they're PCOS, I would just keep things simpler and just assume that they've got the insulin resistance and PCOS and not go any further for the time being, unless again that they give you a very strong family history where it kind of just runs in a multi-generations and the forebears that were not particularly overweight. Right? Yeah.
See, in our country, we are not doing gene testing. So will it make a very big difference if we treat all supposedly GDM patients as GDM and not as Modi?
Look, I think so. I guess you're talking about people who they come back with testing, with the glucose trans test, they come back positive. Look, I guess. I guess in summary, what I would do in that situation is that if you feel clinically if they have features of insulin resistance, again, I would just probably keep things simple and just assume for that time that it's insulin resistance that's driving the glucose intolerance. I probably wouldn't necessarily go any further. Again, but it's more that if you have somebody who's, like I said, even a little bit underweight, and then you just can't explain why it's asymptomatic, and you just can't explain why, then that might be the population that you could potentially. And I'm aware that you may not be able to get any gene testing, but these are the people that you could consider just monitoring them a little bit more in terms of like I said, the fetal growth and all that. And actually, like I said to you, like I do know of a couple of registries around the world. They're interested in getting more data on this sort of thing. Like if you are coming across a lot of these people, you're welcome to contact me. And I can put you in touch with the people who run these registries, because often they actually may be happy to run these tests for you free of charge, because they're trying to get more data about these conditions around the world. And I've actually managed to do them myself in the US. Like occasionally, like most of the insurances in the US cover this kind of testing if we feel like there's a clinical indication. Occasionally come across a couple of insurances which don't kind of, I guess, cover these kind of costs, and these people, they've actually, like I said, managed to do it with me free of charge. So if you are thinking that you are seeing a lot of these people and you really want to get testing done, you could reach out to me afterwards, and Dr. Ravathi has got my contact details. Like if you feel like collectively you are seeing a lot of these people, I can always reach out to these academic cohorts and see whether they may be maybe they may be able to run some of these tests for you. The only thing that you may have to pay for is obviously the mailing, posting the lab samples to Chicago as an example. But I think they're usually happy to run. Like I said, they're trying to get more data on this, and they might be happy to run this free of charge. Right? just keep that in mind, and you can reach out to me.
Thank you so much.
Thank you, Dr. Shen, for that wonderful lecture. And as a token of appreciation, we would like to hand over this memento to you. We will surely courier it across to you. But Dr. Revati, just show the memento.
Okay, well, thank you very much. It's very kind of you. Thank you. Okay, well, thank you very much. Yeah.
Flying all the way to Rhode Island. It's going to be FedEx to you. So, Dr. Prakash Mehta is going to hand over it to you.
You please accept it as a token.
Okay, well, thank you. That's very that's much appreciated, and that's very kind of you. Thank you.
Thank you for being with us and staying awake so late. Thanks.
Oh, no, that's all right. And yeah, thank you for the invitation. Hopefully, we'll keep in touch, and hopefully, I may see some of you possibly in the meeting in Amsterdam, and please keep in touch with me. All right? Thank you.
Sure. Thank you.
Okay. All right.
Right, I think we are now waiting for Dr. Sarosh Rana to join us for the oration from Chicago. She'll be talking to us on biomarkers and its role in preeclampsia. Has she joined us? Not yet. All right, till we are waiting for a few minutes. From Kerala, can we have your introduction?
Good morning, sir.
Yeah, good morning.
I'm Dr. Sreeja. I'm currently pursuing my fellowship of the National Board in high-risk pregnancy and perinatology. I've been a consultant here since the past 3.5 years in the Department of Fetal-Maternal Unit.
Great. Oh, so you'll be joining us for the panel also, right?
Sure.
Great. We as a society, this has been our first year. We have just completed 1 year. This is our first birthday. And so that is why we are having this annual program. But we have been repeatedly having programs wherein we involve a lot of foreign faculty on video conferencing. And
Okay.
before this, we have transmitted already to Ahmedabad. We have been having Bahrain with us for quite a few times. Unfortunately, I think Bahrain did not join this time because I've got some kind of controls over video transmissions now over there. So that is why we could not include Bahrain this time. Hopefully next time they will be coming in. So anytime you would like to join us, we are always there.
Thank you so much, sir.
I think Mumbai is joining us after some more time. Yeah, good morning. Or rather, good night.
Oh, good morning. I know, thanks for late here.
We welcome you for this first oration of the Society for
1 minute, sir. 1 minute. Yeah.
Yeah, Dr. Rana, we welcome you for giving the oration, the first oration of the Society for Maternal Fetal Medicine of India. And to introduce Dr. Rana, we have Dr. Sushma.
Okay. Dr. Sarosh Rana is a maternal-fetal medicine specialist in the University of Chicago, USA. She cares for women with high-risk pregnancy. She is an expert in the diagnosis and management of preeclampsia. Her research over the last several years have focused on demonstrating clinical utility for angiogenic biomarkers in predicting of adverse outcomes among women with suspected preeclampsia. She's been funded by several notable organizations, including the National Institution of Health and the American Heart Association. She's a dedicated teacher. Dr. Rana trains residents and fellows on the use of ultrasound imaging as well as managing women with complex pregnancies. We welcome you, Dr. Sarosh.
Dr. Rana, 1 minute. I will just open up your presentation and give you the controls.
And we also welcome the chairpersons, Dr. Prakash Mehta, who's the chief of maternofetal medicine, Bhagwan Mahavir Jain Hospital, and Dr. Revati S. Rajan, who's a consultant at Mirror Health, Bangalore.
Now I can't see the room, but I'm assuming people can see me. Is that correct?
Yeah, we can see you well. We can hear you too.
Prakash?
Yeah. Are we visible now?
Okay, I can see the room. Can people hear me?
Yeah, you're absolutely clear. And we have Erapal from Kerala also joining us in the other room.
Okay, I can see everyone. Can everyone hear me?
Yes.
Yeah, Dr. Rana, please go ahead.
Okay, great. So good morning, everyone. Everyone. I was saying everyone looks beautiful, so that's fantastic. Yeah. So are my slides looking okay?
Oh, yeah.
Yes, please go ahead.
Okay, great. So essentially, what we are going to talk about in the next, next half an hour, 40 minutes, is kind of this understanding of antigenic factors, and essentially, I kind of called it bench to bedside, just to say how sometimes perhaps discoveries that you make in the lab and essentially with animals, and kind of the journey that you can take, especially as a clinician, to figure out how you can use these biomarkers. So I have some conflict of interest, as previously worked as a consultant to Roche as well as to Thermo Fisher. So these are just drug companies that are making actually these biomarkers to be available for use. And also I currently have some small funding from Roche as well as from Siemens. The outline of the talk is we're going to talk about the antigenic biomarkers and the evolution from how they came about, and also the potential clinical use. And I don't have the study that Revati is currently doing, but obviously, as clinicians, we can think of all different applications that we can use for these biomarkers. So we all know this, preeclampsia is a common hypertensive disorder of pregnancy. The American ACOG recently changed their so now I call it hypertension. Maybe a lot of maternal deaths. So generally in worldwide, about 50,000 maternal deaths are happening because of preeclampsia. And the deaths occur mostly from seizures, so you can have eclampsia or bleeding. In US at least, and I know in other developed countries, it is the leading cause of prematurity. So about 50% of all iatrogenic prematurity is because of preeclampsia. And we all know, and the reason to even be involved in and interested in biomarkers, at least for me, was that it can sometimes present really atypically, and usually there is no treatment. So currently, as of today, there's really no treatment, and preeclampsia has been associated with, and we won't talk about it much, but there is it's associated with long-term cardiac and renal complications. So this is just a slide that I just borrowed from WHO. So every day about 1,000 women are dying from preventable causes related to pregnancy and childbirth. So that's a very large number. So for example, that will amount to in 2013, about 300,000 women died from preventable causes, and about 99% of these deaths are happening in the developing countries, 50% in sub-Saharan Africa. And preeclampsia is number 2. So out of all the deaths, preeclampsia is responsible for a large burden. So here is kind of their, this was also from 2013, 2014, and 27% this is severe bleeding, 14% is pregnancy-induced hypertension. And a large number of these bleeding actually are also related to pregnancy-induced hypertension. So it's a major cause of global burden of disease. This is the hypothesis that was prevalent in the lab. So this is Dr. Karamanchi, who essentially discovered the proteins in 2003. So essentially what we believe is that preeclampsia is a placental dysfunction, so there's something wrong with the placenta. And that could be from many different reasons. And we're not going to talk about it much, but again, they could be, people have worked on autoantibodies, so there could be AT1 autoantibodies. You can have natural killer cells, so these are the cells that are routinely present in the maternal fetal interface, and they can be kind of bad cells there, or different kind of cells that may be present that may lead to placental dysfunction. There are genetic factors. Oxidative stress is actually a big mechanism that people have studied as a cause of placental dysfunction. But essentially what we believe is because of the placental dysfunction, there is release of certain factors into the maternal circulation. So there's release of this protein called soluble FLT1, other proteins such as soluble endoglin, and essentially what soluble FLT does, it causes widespread endothelial dysfunction. So essentially endothelium in the blood vessels, it can affect the glomerular endothelium in the kidney, so you can have proteinuria. It can affect the sinusoidal endothelium, that's why you can have transaminitis, or it can obviously cause cerebral edema. So there are animal models whereby overexpression of soluble FLT has been shown to pretty much replicate all clinical signs of preeclampsia. So essentially this is the slide showing how you can perhaps understand this. So if you look at the top picture, essentially those cells are your endothelial cells, and you have these receptors, which are the FLT1, which is the receptor which has these little, like that semicircle space where you can actually bind to VEGF and PLGF. So placental growth factor and vascular endothelial growth factors are growth factors. So they're present in pregnancy, and essentially the PLGF and VEGF, these little green and blue circles, they dock and they sit and they have this receptor protein called FLT1. So essentially when they come and they bind to FLT1, there's downstream signaling because they're attached, the FLT1 protein. Yes?
There seems to be some concern with your microphone. Are you using the laptop microphone?
Yeah.
There's some disturbance. There's some disturbance on your microphone.
Is it better now?
Yes, I think it's better now. Please continue.
Is it? Okay, I made it the volume high.
Is there a headphone at hand?
Yeah, I can find one. Do you want me to find one?
No. You can do it. Is it okay now? Okay.
Is it better now?
Okay, fine.
Kerala, you can hear well?
I can hear really well, yeah.
Yeah, okay, sure. We go ahead.
What about the other? Okay. So these proteins, the PLGF and VEGF, they bind to the cell surface bound FLT1 receptor. And because the FLT1 receptor is bound to the endothelial surface, there is downstream signaling. The soluble FLT1 is just a truncated protein that has this VEGF and PLGF binding domain, but essentially does not have the cell surface receptor domain. So essentially, if there's lots of soluble FLT in the circulation, it will bind to VEGF and PLGF, and essentially there will be less VEGF and PLGF remaining to bind to the actual FLT1 receptor, which will cause endothelial dysfunction. So there is no downstream signaling happening from VEGF and PLGF because of presence of soluble FLT. So essentially this was kind of shown in the Western blots, whereby initially Dr. Karamanchi was able to show that the protein soluble FLT was high in the placentas that came out of the women who had preeclampsia. And very soon thereafter its discovery, what they did was they looked in a large cohort of patients whereby they collected samples throughout their pregnancies, and they were able to show that the soluble FLT PLGF ratio that was being calculated, it was very high in women who ultimately developed preeclampsia, especially preterm preeclampsia less than 37 weeks. So essentially, this is the time zero, this is at the time of diagnosis, this is 5 weeks before the diagnosis, 6 to 8 weeks before the diagnosis. So as you can see, the levels of soluble FLT and PLGF was so much higher in women even months prior to the clinical diagnosis of preeclampsia. So what would be the diagnostic and therapeutic implications of soluble FLIT then? So there are two concepts. One, if soluble FLIT is elevated prior to the development of maternal syndrome, so based on the studies, early studies that was done, perhaps people thought that it could be used as a diagnostic or a predictive test. So because it's coming before the preeclampsia is actually happening, perhaps you can use it to diagnose preeclampsia like before the clinical features. And number two, I think if it's important in terms of pathogenesis of the disease, you can devise treatments that would interfere with the effects of soluble FLIT. Or perhaps you can reduce soluble FLIT, or you can increase the pro-angiogenesis, so you can increase the PLGF and perhaps even VEGF, and you can maybe prevent or even treat preeclampsia. So there are various types of clinical studies that have been done since the protein has been discovered. So there are diagnostic studies. I'm going to show you a few kind of the studies that were either done by us or kind of along these lines. So diagnostic studies will be the ones that are to establish the diagnosis of preeclampsia. So at the time of the disease, whether soluble FLIT is high and PLGF is low. There are lots of studies now in publication whereby soluble FLIT PLGF has been used in patients who have overlapping signs of preeclampsia, such as patients with lupus and gestational thrombocytopenia. So you can differentiate whether the person has lupus or whether the person has gestational thrombocytopenia compared to patients, for example, who have preeclampsia, and they have very, very overlapping symptoms with lupus especially. We did a lot of studies, and obviously the big New England Journal article by Dr. Stefan, whereby they showed that you can measure it in the third trimester among patients who have clinical suspicion of preeclampsia and can actually use it as a rule out or a rule in test. It can be used for prediction of postpartum hypertension. I've done some studies myself whereby you can look at antepartum soluble FLIT, which predicts postpartum hypertension. And then there was, again, studies done by us in Haiti as well as other groups, which have shown that perhaps it can be used in developing countries mostly as a rule-in test rather than rule out. And then I'll talk about the angiogenic factor-based therapies. So let's talk about a couple of diagnostic studies. So this was a study published now almost 8 years ago, 2010. Essentially what they did was they collected blood all throughout the pregnancy prospectively from 20 weeks to 36 weeks from about 457 subjects that were enrolled all across the United States in the prospective clinical study. And essentially they were testing a new prototype, which was actually one of the first studies that they showed that it can be done on an automated platform, because before this, all the studies that were published, especially Dr. Karamanchi's group, they were doing it in the lab manually, which was manual ELISAs can take about 6 to 8 hours. So this was done on an automated platform, and they were interested in looking at the diagnostic cutoff, so what will be the sensitivity and specificity of such a test. So essentially, if you look at these graphs, the top one is the soluble FLIT one, the bottom one is the PLGF. And essentially what you see is that patients, so the blue ones are no preeclampsia, blue dots, and the red dots are preeclampsia. And essentially what you can see that patients who had preeclampsia, so all the red dots, had a higher soluble FLIT. And the bottom, kind of the x-axis is the gestational age. As you can see, as the gestational age advances, there is some mixing in here at maybe at 37 weeks between there are some reds in the blue zone and there are a couple of blue in the red zone. But definitely when you were early, definitely less than 35 weeks, you can clearly see that patients who had at least a diagnosis of preeclampsia, clinically diagnosed with preeclampsia, they had much higher soluble FLIT. Similarly, when you look at the lower graph, at the PLGF, again, red are the people who had preeclampsia. PLGF was much lower, especially at early gestational ages in patients who had preeclampsia compared to similar gestational age who did not develop preeclampsia. So they went ahead, and obviously if you calculate the ratio, and in our hands, two ratios always performed a little bit better than either soluble FLIT or PLGF, at least in terms of sensitivity and specificities. And as you can see, the ratio here, patients who had preeclampsia had much higher ratio. So the red dots are the patients who had preeclampsia. On the y-axis is your actual ratio. And especially in early gestational ages, there is this one red who was in the blue zone, but we don't know if the diagnosis was correct or not. But regardless, you can clearly see that patients who have preeclampsia have a much higher ratio compared to patients who don't at gestationally aged matched. And then when they created an ROC curve, they got a very, very good AUC, area under the curve of almost 0.99. So that's almost a perfect area under the curve of 1.0 is like the best diagnostic test. So they were able to show that at least at the time of diagnosis, soluble fluid PLGF ratio is very high in patients who have preeclampsia. Then just following that, and there are multiple other studies, but I just pulled out a few of them. So this was a study done by Dr. Walrahan. He's in Berlin, Germany. And essentially at about the same time, 2009, 2010, they also took a whole bunch of patients. I don't know how clear is the graph, but they had this bottom line is the gestational age in the top left graph. The y-axis is the analytes, so they were able to show, again, the red is the patients who had preeclampsia. The patients who had preeclampsia had much lower PLGF, much higher soluble fluid, and a much higher ratio. And they kind of came up with this cutoff of 85, which gave them the best sensitivity. So they said that the ratio of 85 results in the sensitivity of 82%. So reasonable sensitivity, but very, very good specificity of 95%. And then they looked at the subgroup of patients who had preterm preeclampsia, so early onset preeclampsia defined as less than 34 weeks. And they were able to show that at the same cutoff of 85, the ratio resulted in the sensitivity slightly better, 89%, but very good specificity of 97%. So when you have a very high specificity, you can tell that the test is perhaps a very good rule-out test. This was a very recent meta-analysis then based on multiple different studies published in 2015. And essentially what they showed that they were looking at the diagnostic accuracy of soluble fluid PLGF. They were able to find 20 different studies. And essentially what they pooled all the studies and looked at the diagnostic sensitivity and specificity and came up with a sensitivity of 0.78, so reasonable sensitivity, but better specificity of 0.84 and area under the curve of 0.88 in all gestational ages. And when they limited their analysis to gestational age less than 34 weeks, they had an area under the curve of 0.98 and a very high pool diagnostic odds ratio of like 200. So clearly, I don't think many people are now studying soluble fluid PLGF ratio in the context of diagnosis, because I think there are lots of studies out there and pretty much everybody saying that it has good diagnostic accuracy. Now I was talking about you can actually essentially use this test, or perhaps people have studied it in the context of patients who have lupus or patients who have chronic kidney disease. So this was published by a group in 2013, and essentially they had patients who had preeclampsia, chronic kidney disease, and control subjects, and they just measured patients who had known kidney disease, and they knew that those patients had no evidence of preeclampsia, and they looked at the soluble fluid PLGF ratio. So in this paper, I don't have the graph here, but the creatinine sometimes was much abnormal also in patients with chronic kidney disease, but the degree of proteinuria was sometimes not different between chronic kidney disease and preeclampsia. So essentially, there was a diagnostic conundrum sometimes, and what they did in clear cases of preeclampsia, they found that the soluble fluid was really high, the PLGF was very low, which by the way, in chronic kidney disease, the PLGF was even higher than the controls. But essentially, when they looked at the ratio, as you can see here, the soluble fluid PLGF ratio was so high in patients who had a clinical diagnosis of preeclampsia compared to patients who have chronic kidney disease and patients who were controlled. So clearly, if you have patients who have underlying chronic hypertension or patients who have underlying chronic kidney disease, they will have hypertension, they will have proteinuria. So your diagnostic criteria is not that great, because you can get confused by whether this is preeclampsia or not. And clearly, if you were to measure the biomarkers, perhaps the biomarkers will be obviously very abnormal in patients who have preeclampsia compared to patients who have kidney disease. And then they just plotted it out and seemed like there was no patients. So in the lower graph, these are the number of patients, and that's the ratio. And as you can see, the gray and the circles, uncolored circles are patients who were controlled and patients with chronic kidney disease. Very, very low ratio in all these patients compared to patients who had preeclampsia who had a very, very high ratio. Now, this was a study that I did when I was in Boston with one of my residents. And essentially, we had a very small study that had about 25 patients. And essentially what we did was we took patients who has HELLP syndrome, known HELLP syndrome. So those are the red dots. We then compared them to patients who had thrombocytopenia from, for example, gestational thrombocytopenia. So these were the patients who had known diagnosis of gestational thrombocytopenia, and then we had controls. And essentially what we were able to show that both the patients who had HELLP and thrombocytopenia, they had very low platelet count, but the patients who had HELLP syndrome had a very, very high ratio. So those red dots were extremely high ratio in patients who had a known, clinical diagnosis of HELLP syndrome. What about prediction studies? So I think there are lots of diagnostic studies done. So what about the prediction studies? So prediction, you're trying to figure out the disease doesn't exist. You're trying to figure out how somehow perhaps you can use it in early pregnancy before the disease arrives to predict preeclampsia. So I'm going to talk about kind of two different ways. One is the studies that we did and the recent study that was published by Poon to predict in the first trimester. So the story goes that very, very early on in 2003, 2005, a lot of people actually did first trimester screening and came back negative because the diagnostic criteria is not good. 37 weeks is too far away. So I think I'm not going to talk about any prognostic studies in the first trimester. They were a big failure in terms of giving very poor positive predictive values if you were to measure that in the first trimester to predict alone, for example, for soluble for PLGF in the first trimester to predict term preeclampsia. But we're going to talk about prediction studies actually in the third trimester. So how can you use soluble fluid PLGF ratio? And here we kind of changed our outcome, not just preeclampsia, but we were also interested in adverse outcomes that are related to preeclampsia, because I was never convinced as a clinician that preeclampsia is a relevant diagnosis unless it's associated with adverse outcomes. So if preeclampsia leads to preterm delivery, that's a bad preeclampsia. If the preeclampsia leads to HELLP, that's a bad preeclampsia. But if you only have hypertension, proteinuria, and you deliver at term or have a good sized baby, I just do not think that's, of course you can study the disease, but it never felt that that's something that you want to use your biomarkers for. So this is the first study that we did, whereby we actually took 600 patients in triage, which were coming for evaluation of preeclampsia. And essentially what we said, let's see if the biomarkers in triage will predict adverse outcomes that are happening within 2 weeks. So essentially in this top left graph, you see 4 different categories of patients. NHD is no hypertensive disorder. Then we had bunch of patients with chronic hypertension, bunch of patients who had gestational hypertension, and then patients who had known diagnosis of preeclampsia either in triage or majority of the patients developed them in the next coming weeks. And essentially what we were able to show that soluble fluid PLGF ratio was very high in patients who had preeclampsia diagnosed within 2 weeks. And essentially, we were also able to show that not only the preeclampsia, the soluble fluid PLGF ratio was high in preeclampsia, but when we have predefined adverse outcomes, and those were like presence of transaminitis, thrombocytopenia, preterm severe hypertension, you could see that the ratio was much higher in patients who had adverse outcomes versus who didn't. And essentially, you could draw this line at the bottom of the patients who had, yes, adverse outcome, and this line was falling at 85. So we then, and then if you look on the bottom left, it was not just any adverse outcomes, but most common adverse outcomes, all of them had a high ratio. So when we went ahead and did the ROC curves, we were able to show that the ratio by itself had a pretty good ROC of 0.89, which was better than any other test that you were using at that time in triage. So these are all the other tests that we were ordered on the patients in triage: the creatinine, uric acid, AST, ALT, systolic blood pressure, and we were able to show that the soluble fluid PLGF ratio was actually performing all these standard clinical tests that we typically use in triage for evaluation of preeclampsia. And then not only it was related, like I was saying, it is important to see what's ultimately going to happen, and we were able to show that the soluble fluid PLGF ratio was inversely related to the time of presentation to delivery. So the higher your level, the faster you get delivered, because obviously these patients were getting clinical care. And this becomes relevant when you're talking about, for example, using this test in developing countries where you may not have access to delivery quickly. And perhaps you can say that if a patient who had a high ratio, if she comes, you can perhaps transfer her, because here this is a very kind of a controlled situation. We're talking about patients in Boston. But regardless, we were able to show that high ratio leads to quick deliveries. And then when you look at the Kaplan-Meier curve, the blue line here on the right side is the patients who, that is the predictability of remaining undelivered compared to patients who had the high ratios. As you can see, the red line is the high ratio, And essentially what we were able to show that patients who had a high ratio delivered within 1 to 2 weeks. Essentially, majority of the patients were delivered within 2 weeks compared to patients who had a low ratio whose pregnancy kept going on and on and on. And essentially, if you were to think of any drug treatment, you will try to bring this red line back to the blue line. That would be the ideal kind of the treatment whereby you know that this patient is going to deliver early or deliver within the next 1 to 2 weeks based on her biomarkers. And then somehow if you can modify those biomarkers and then maybe continue her pregnancy a little bit farther. So this was, our paper was published in 2012, and this was the new, now not so new, New England Journal of Medicine paper published in 2016 by Dr. Stefan Walrahan group. And essentially they took the exact same patient cohort in Germany and 15 other countries in Europe, and they validated this ratio in ruling out preeclampsia. So pretty much they were very interested in the negative predictive value, and essentially they had pretty similar study design that ours. They took patients in triage, measured their soluble FLT PLGF on an automated platform, and then looked at the ROC curves. And they had two different kinds of cohorts. The development cohort is where they developed the ideal cutoff, which was 38, and then they had the validation cohort, which they then applied this cutoff to the population. And essentially, for statistician, we need to know if the ratio is low, it'll be a very good negative test. So they obviously did not want to miss any patients. So they actually came back with saying that perhaps a better cutoff to rule out preeclampsia should be 38. And based on this, what they were able to show that the negative predictive value to rule out preeclampsia within a week was 99.3%. So essentially, if you get a patient whose ratio is very low, so if it's less than 38, the chances that that patient will develop preeclampsia within a week of arrival is exceedingly low. So you can essentially, send her home or do whatever you need to do. So this was another study that we published, kind of talking about the pregnancy duration. In this case, what we did was, this was one of my fellows, and essentially we took 100 patients who were coming in with a diagnosis of preeclampsia, with a known diagnosis of preeclampsia, and we were interested to see what happens to their levels on a day-to-day basis. So if you come in with a particular soluble FLT PLGF ratio, and if it keeps going up and up, do those patients do worse than patients who have a low ratio, and do the ratios stay flat in some patients? So essentially in the top graph, you can see those red ones are the patients who came with a high ratio, and every day of the measurement, so we measured soluble FLT PLGF every day for the first 3 days, and then samples were collected weekly afterwards. These samples were all measured retrospectively, so none of the values were available in real time. But essentially what we were able to show that if the ratio was high and it kept going up, the patient got delivered very, very quickly. So the bottom days are the days of delivery. So essentially the mean duration of pregnancy was 6 days compared to patients who had a low ratio. So that's those green people, green dots, who then continued their pregnancy along much longer in patients who had a low ratio, and their ratio continued to be low. So the positive predictive value from this data for delivery within 2 weeks was about 91%. Again, I think there's lots of kind of controversy as how exactly you would use the test. So me and Anand keep going back and forth. Sometimes we think it's a good rule out test. Sometimes we think it's a good rule in test. So definitely it also has a very good positive predictive value. At least in our hands, we found that if you were to measure this, and this is on arrival in patients who had a diagnosis of preeclampsia, if the ratio is high, you have a very high positive predictive value. So like I was saying this, what about the first trimester prediction of preeclampsia? So this was the study that was published now in 2009 by Poon. And based on this, obviously, they now went back and did the ASPER trial, whereby so in this study published in 2009, they were looking at a very large cohort of patients, whereby they measured different things in the first trimester, which included the uterine artery Dopplers. They looked at maternal characteristics, past history of preeclampsia, mean arterial pressure, and they measured serum biomarkers. They measured PLGF and PAPE. And essentially what they were able to show that a combination of these characteristics as well as biomarkers had a positive predictive value of 93.5, which is a very good positive predictive value. For everyone to know, if you just only do the maternal characteristics, the positive predictive value will be very low, it will be like 20%. So they were able to show that with the use of uterine artery Dopplers, mean arterial pressure, PLGF and PAPE, they raised the positive predictive value up to 93%, and with a 5% false positive rate. So I think it's a very good predictive test. Obviously, they went back and did the ASPIR trial, whereby now they're giving aspirin only to patients who are positive based on the biomarkers in the first trimester. So certainly the utility of measuring the soluble fit PLGF in the first trimester would be to figure out who are the patients who are at risk and perhaps give them risk-modifying treatments such as aspirin. So obviously we don't do this in US, but definitely in England, they routinely are doing mean arterial pressures, and they routinely are doing uterine artery Dopplers and soluble fit and PAPE and predicting what's the risk for preeclampsia, and then if you are high risk, you get aspirin. So what about postpartum hypertension? Again, this study was done by one of our fellows in Boston, and essentially what we showed that we took about 1,000 patients who were undergoing a C-section, and we collected their sample before delivery and looked at the blood pressures after delivery, all the way up to 6 weeks. And what we were able to show, for example, in this left graph here, so postpartum hypertension was defined as blood pressures more than 140/90 after delivery. And essentially you can see that as the blood pressures, as the quintiles of soluble fit PLGF was rising, the proportion of patients who will have postpartum hypertension was high. So essentially meaning that, and this will make sense because a lot of patients who have antepartum preeclampsia, especially severe kind, end up with postpartum hypertension. So not that it's a perfect biomarker, but currently there is nothing that predicts postpartum hypertension, and it's a very enigmatic disease. So at least if you have somebody's antepartum level, you can make some predictions for postpartum blood pressures as well. Now, what about the developing countries? So this was, again, one of my fellows. We published this in 2015, and I was always interested in figuring out, what kind of the soluble fit PLGF is also high in patients, for example, who have eclampsia, patients who actually, if there is a maternal fetal death. So we don't have that in Boston. We don't have that in Chicago. But certainly, when we went to Haiti, we took a bunch of patients who had all different kinds of manifestations of preeclampsia. So for example, we divided them into 4 different categories. Category 1 were patients who had, and this is on admission, severe hypertension on admission. Category 2, patients who had abruption or renal failure, growth restriction. Category 3, patients who had eclampsia. Category 4, patients who had maternal fetal death. And composite category was any of those categories. So this was in patients with early onset, adverse outcomes less than 34 weeks. As you can see, the patients who had none of these adverse outcomes had low soluble fit PLGF ratio compared to patients who have any of these adverse outcomes. Severe hypertension was actually not present as an isolated adverse outcome in any patients. So every patient had one thing or the other. And Haiti is like really bad because they had lots of maternal death. So we can see here that the soluble fit PLGF ratio was very high in pretty much all complications related to preeclampsia. So this is kind of an editorial that I recently wrote in 2017. I think the slide didn't come out well, but I think we can go through it. So essentially what is happening right now is whenever we are assessing a patient for risk of complications, so that's why you guys are all doing prenatal care, I'm doing prenatal care, there's some sort of prenatal care going on whenever there's a pregnant patient. And essentially there are 2 ways that the patient can go. One is this what we are doing currently. It's a conventional approach where essentially what we guys are doing, we're checking blood pressures and urine protein, we're evaluating the patient for clinical signs of symptoms of preeclampsia, which are very non-specific. So essentially what ends up is that it's a very resource intense kind of a situation. You have to keep checking on the patients multiple times. Just doing clinical assessment for preeclampsia has a very low sensitivity and specificity. It's not really cost effective because you need a clinic, you need like lots of people to figure out whether she has preeclampsia or not. Traditionally, it has, for example, blood pressure by itself or proteinuria by itself has very poor positive and negative predictive value. And then it requires constant access to high quality care. So obviously you need to have physicians and clinicians who can figure out based on blood pressures and proteinuria and labs, does or does not the patient has preeclampsia. So obviously the other big problem is that this way all patients are treated the same way. So whether you are at high risk or low risk, because we are not based on biomarkers, you just kind of keep going in this cycle over and over again. That's the model that we are using here in the United States. But the thing is, it's okay maybe because majority of the patients are receiving prenatal care, but I think some part of it may lead to iatrogenic prematurity, but certainly not a very good model. What perhaps you can do though is what's written on the right side, that you can do perhaps something called personalized care. So somehow in between her pregnancies, and again, nobody's done this study, this was just an editorial that I wrote, think that perhaps during pregnancy, and I don't know how many times, what gestational age, but perhaps you can do some sort of a biomarker-based risk assessment. So this could be done in the first trimester, for example, if you're in Europe and you want to do all your biomarkers and your Dopplers, but this can also be done at the time of clinical suspicion of preeclampsia. So you can do your routine prenatal care, but anytime you have a suspicion of preeclampsia, you can stop and check the biomarkers. This will be actually less resources, because I think you can rule out a lot of people who are not really at risk for preeclampsia, not really at risk for adverse outcomes. It has typically high sensitivity and specificity. I think in the end it will be much more cost effective, because you'll be saving some resources by triaging patients appropriately. It definitely has a high positive and negative predictive value. I think personally this measurement of biomarkers requires less expertise, because anybody can read it and interpret it. So if I say a number of 38, that means something, and that means something for everyone. A blood pressure of 160/100 may mean something different to me because I know what to do with it, but it may mean nothing to a person who doesn't know what to do with it. So at least if you have biomarker-based management algorithms, it will mean the same to everyone. And I think it requires less expertise, because you don't have to put complicated, scenarios in your head. I think it's going to prevent adverse outcomes. So based on all these, you can stratify patients into two kinds of risk categories: low risk, which will be majority of the patients who can continue the prenatal care, and then high risk, whereby you can transfer them to a higher level facility, especially in developing countries, and perhaps reduce maternal mortality. Okay, we're going to just kind of touch base on the strategies for therapy. So there are few different strategies that somebody can think about. So if soluble FIT is the bad protein and VEGF and PLGF are the good proteins, you can perhaps think that you can give back the good protein. So perhaps you can infuse or somehow give them VEGF and PLGF. Then you can use antibodies against soluble FIT, because you can just neutralize the soluble FIT that is in the circulation. And most of these studies have now been done in animals and some of them in humans. You can also remove the soluble FIT. For example, somehow you can come up with a column or something that removes soluble FIT. And then something that we've been interested in, there are other labs as well, whereby you can screen for some small molecules or silencing RNAs that can block the soluble FIT production. So you can either remove it from the circulation, you can either bind something to it so that it doesn't act, or you can perhaps do some small molecule screening. So why do we even need to treat preeclampsia? Well, because one, it will prevent maternal morbidity, but then you can also prevent maternal morbidity just by simply delivering the patient. But you can't really deliver the patient at early gestational ages. So there is some benefit in treating people if they have preeclampsia, especially severe early onset preeclampsia between 24, 26, 28 weeks. As you can see, this is a graph which shows what are the different kind of neonatal complications. And as you can see, by 30 weeks, pretty much all neonatal complications are coming to an end, except for RDS. So this is the data from US. So the blue line is the respiratory distress, which dramatically reduces after 32 weeks. Sepsis also, all those intraventricular hemorrhage, necrotizing enterocolitis, those complications are almost disappearing by 30 to 34 weeks. So if you were to do any treatment, you're probably targeting a patient population between 24, 26, 28 weeks, because at that gestational age, the risk of all these complications are really large. So what you're trying to do, if you can push the gestational age to the right, even by 1 or 2 weeks, I think that will have significant impact on the neonatal morbidity just from the early gestational age delivery. So what would be the rationale? Why would you even think about using soluble FIT? So certainly, I hope I've told you in the previous 30 minutes that soluble FIT levels correlate with adverse outcomes, so not just with the diagnosis, but clearly there's evidence that soluble FIT levels correlate with adverse outcomes. There's actually studies looking at depletion of soluble FIT in the preeclamptic placenta using antibodies. So in cell culture studies, they took the preeclamptic placenta, did some experiments and say, well, preeclamptic plasma is bad, and then you add the neutralizing antibodies, it reverses the anti-angiogenic phenotype. There are studies in animals whereby lowering the soluble FIT, or you can antagonize soluble FIT in the animal models, and it improves the clinical symptoms of preeclampsia in animals. And also there are some experiments going on in nature, such as there is spontaneous resolution of preeclampsia in patients. For example, there was a twin in which there was a baby who had high drops in a singleton pregnancy, or removal of the diseased placenta in multiple pregnancies. So there are some evidence, for example, in this hydropic baby, the soluble fluid was really high, and they treated the high drops, and the soluble fluid went down, and the patient became better. Her preeclampsia actually resolved. So there's a couple of experiments. This was done in 2007, and none of this, definitely the recombinant VEGF did not really work out. I know there are some experiments going on in Dr. Anne-Marie Hennessy's lab in Australia, where they are doing recombinant PLGF. But this was one of the early studies done in 2007, whereby they gave the VEGF 121. And essentially what they showed, that given VEGF 121, it did not, so this is naive, is the blue, is the cells that had, are the rats that have nothing. VEGF 121 is and the orange and the pink, because I hope you see the same colors as I'm seeing here. Those were the two rats were infected with soluble fluid. So as you can see, the orange had the higher blood pressures, and then when you gave them VEGF 121, the blood pressures came down. Similarly, as you can see, the orange, the vehicle had a soluble fluid high and had no treatment for soluble fluid. The pup weights were lower, and then when you gave VEGF 121, the pup weights were a little bit higher. But the most important kind of, I think, when I look at it, is that the protein albumin creatinine ratio was so high in the vehicle, in the control animals, compared to when you gave VEGF, it's kind of almost made this PC ratio, albumin creatinine ratio, disappear. And then they looked at the kidneys, and they were able to show that when the soluble fluid is overexpressed, there's lots of glomerular endotheliosis, and then when you rescue it with VEGF 121, the glomerular endotheliosis becomes better. What about doing some studies in humans? So this is Dr. Ravi Thadani, was a Mass Journal, and essentially what he did was he created this column, which is a liposorber column, which takes out your, it's like actually a cholesterol, takes out the cholesterol in patients who have hypertriglyceridemia. But essentially what he wanted to do, he wanted to create a column similar to this and see if we can perhaps remove soluble fat. So it's kind of a dialysis, similar to dialysis treatment, in which he would attach patients to this machine, which will then, the blood will go through this column, and that will reduce the soluble fat. So this was published in 2011, and what he did was he took some pregnant patients who had preterm preeclampsia between 24 and 30 weeks, because that's where you want to make the most difference. And these patients not just had the clinical diagnosis of preeclampsia, but also had a very high soluble fat levels. And essentially what he did was, before he did it in actual pregnant patients, he took human blood, spiked it with soluble fat, and ran it through his column. And he was able to show that every time he runs it through the column, the soluble fat the soluble fat concentrations goes down. So post one is one treatment through the column, that blue bar, very low levels, and then after 2 or 3 treatments, the levels of the soluble fat in that spiked plasma was very low. So the column was working. What was his primary outcome? He really, in this study in 2011, he really set out to see if you can actually safely reduce soluble fat in pregnant patients. So he just wanted to determine whether if you do a short-term pheresis using this device, it'll lead to reduction of soluble fat in the blood of women who were suffering from preterm preeclampsia. And then he also said that perhaps if you were able to reduce soluble fat, you can stabilize her blood pressures and reduce proteinuria, you can prolong her pregnancy, and you can increase the fetal weight. And he was also interested in to determine what is the safety of reducing soluble fat in an actual human being. So what he did was he, obviously now this is very smart study, because you're not only basing your treatment based on diagnosis, but because you're removing soluble fat, he essentially took patients who had high soluble fat. It won't make sense to remove soluble fat from patients who have a low soluble fat, because about 50% of preeclamptics, we've shown that, actually have normal soluble fat. So the treatment would not apply to every preeclamptic patient, but they only took patients who had a very high soluble fat, so such as 7,000, 10,000. And as a baseline, they looked at 7 patients who had preterm preeclampsia and showed, like our previous study, that if you have a high soluble fat, you get delivered very fast. In this study, they were delivering in about 4 days. Those arrows are the soluble fat trajectory in each of those patients. They had multiple points, and they were able to show that if your ratio is high, you get delivered very quickly. And then he took patients, and this is a pretty threatening machine, but apparently it's very easy to use. But you connect the patient to a large bore IV, the blood circulates through it. It's pretty similar to dialysis. And essentially these, on the right side, they showed the pheresis treatment at each line, and every time they would do a pheresis treatment, the soluble fit will actually go down and then stay low, and then it'll come back up, and then it'll go down again, come back up, go down again. And there was one patient who was treated with 4 levels of 4 times pheresis, and she was able to prolong her pregnancy beyond 20 days. So this is a more recent study that he did, a multi-center study now, this time in 2015. And essentially it wasn't randomized, but it was kind of quasi-randomized. It took patients who were being treated at the same time. So they had control patients, the ones which are blue, and they measured the soluble fit PLGF and say, okay, how far do you go? So the blue lines are the are the latency in terms of how many days of pregnancy. And then the red bars are red lines are the patients who were treated. So as you can see, in control group, pretty much patients got delivered in 3 days, while in one treatment, the average prolongation was 8 days, so anywhere from 2 to 11 days. And then with 2 treatments or more than 2 treatments, the average duration of pregnancy was 15 days, and it was ranging from 11 to 21 days. So pretty kind of convincing data that if you were to use it in the right patient population, such as the soluble fit is high, and you remove the soluble fit, perhaps the pregnancy is going to go further. So I think what they're trying to do now is to bring this device to US. The study was all done in Europe and France, and see if we can actually do a multi-site study in the US. Then I'm not going to touch on this much, but there are other labs and people who are trying to figure out small molecules. Now for me, pheresis device is a good thing. I mean, if it works out, it's perfect. But I don't think we can use the pheresis in Haiti. They can't even place an IV, forget about putting a patient on dialysis. So I think we need to come up with things that are perhaps, a pill or even a vaccine or something like really intelligent. So there are people who are looking at small molecules, such as there's a trial ongoing right now for statins. So I didn't talk about it, but there's lots of data that statins actually increase VEGF and reduces soluble fit in animals. It reduces soluble fit in placental cultures. And there's a randomized trial currently going on in America to look at the use of statins in the first, second trimester for reduction of preeclampsia. We published this paper on Obane. We are still carrying on with different hits that we found for using small molecules. And obviously, like I said, there are studies going on to look for small silencing RNAs which can be used for reducing soluble fit. So this is kind of a couple of end slides. So I think I hope I'm able to kind of convince you that the circulating soluble fit is secreted by the placenta, and it is increased in patients who have preeclampsia. I don't think there's any doubt about that. I think the elevated levels of soluble fit and low levels of PLGF, it can serve as a diagnostic or a predictive marker of preeclampsia. So I didn't show you this, but these biomarkers are now approved. So for example, the Roche biomarker that was done, the study done in Germany, it's approved in Europe, it's approved in Canada. There are other companies such as Thermo Fisher. They're trying to develop a tabletop analyzer that is also approved in Germany. It's also approved in Australia. So I think people are using it, at least for now, in the NICE guidelines, which are the guidelines in England. They put that PLGF can be used as a predictive marker, as a rule-out test in the third trimester when somebody's coming with clinical suspicion of preeclampsia. So certainly, the US, we are just about ready to do FDA studies, but certainly I think it can serve either as a diagnostic marker when there's a diagnostic conundrum, or as a predictive marker for preeclampsia. And I think depletion and reduction of soluble fit will actually turn out, hopefully can come up with some therapeutic benefit. Now, before I let you go, I'm just going to acknowledge some people. This person on the upper left is Dr. Karamanchi. I used to work in the lab with him. We used to collaborate. And Dr. Thadani, and then the top right is Dr. Lindheimer, who is a very old professor at the University of Chicago, and he wrote papers about preeclampsia in 1970s, long before we were even born. He was writing in the New England Journal of Medicine, so he's very good. He used to be he used to be Anand's mentor as well. So he used to be in Chicago. Now he's retired, gone to California, and that's my kind of team there. people that I work and they collect samples every day. Just acknowledgement to people. So I do work with Stefan in Berlin. We have, and then obviously the doctors in Haiti and my funding. And that's all I have. Thank you.
Thank you so much, Dr. Sarosh. This is Revati. We are really delighted to have you present the first oration for the Society for Metal Field Medicine India. And we're really happy that the society is 1 year old now, and you've been constantly supporting us as an international advisor. And we have Dr. Prakash Mehta, who's the president of the society, who's going to be doing the honors now.
I'll read out the plaque. This is a plaque in sterling silver. The Society for Maternal Fetal Medicine India honors Dr. Sarosh Rana, MD, MPH, FACOG, Chief of Maternal Fetal Medicine and Professor of OBG, University of Chicago, for delivering the oration Angiogenic Factors from Bench to Bedside during the first annual conference of 6th May 2018. This is the plaque, and we'll make sure that it is FedEx to you. So thank you very much, and we hope that we'll have you more often in future. And if I may digress a little bit, I hope you'll be coming for AICOG 2019. I hope so.
I hope so. What month?
Is that January?
What month?
8 to 12 January 2019. So,
I don't know. We'll do this. This is easy. I'm actually coming to India in November for this grant that we wrote through there's a Center for Global Health in New Delhi, and we wrote that grant as a kind of, we wanted to do an education, and that grant got funded. So I'm going to come in November to Delhi, and I think it'll be very difficult for me to come in November and then go back and in January. But I'm so sorry. I know we were trying to figure that out.
Sure.
Thank you so much, Dr. Sarosh, for your time, and we held you late at night for the excellent oration. And there was so much of information on the SPLIT1 PLGF, and the crowd is definitely going to be convinced about doing the test and ruling out more atypical preeclampsias. So with this, no questions for the oration. So Edapal is also saying bye to you. So there's another center in Kerala who's joined us. Yes, it seems easy to be joining in like this, actually, connecting across continents and online. Thank you so much, Dr. Sarosh.
Thank you.
Thank you.
Thank you very much. All of you guys look beautiful. Carry on the good work, Revati. You'll be presenting soon.
Yes.
Very good.
Thank you, and
Okay, take
good
care.
night. Good night.
Now we break for coffee.
So I need to get 70, then I do the RCT. It's tough, but we need to do it.
Excuse me, Dr. Yagnik's presentation starts at 11:30 sharp. So please be back here in. Where? Okay. 11:10. Okay, fine.
Just 10 minutes in between the coffee break and inauguration, so you have to attend.
Yeah, arrange the doesn't matter. Those who have to get their posters judged, please be near your posters. Those whose posters have to be judged, please be near the posters.
Yes, I'll hand over the I have authorized you as a presenter now. Don't bother about the. Okay, can you load your presentation?
So we say open document, isn't it? Yeah. Okay, I'm just going to do it. अच्छा हे तुझ्याकडे एअरटेलचं ते आहे का मी त्यातलं हे लहान घेतलंय हे तर काय असं काय फार ब्रिलियंट चालतं असं काही नाही हे चांगलं चालतं का
Dr. Yagnik, were you able to load your presentation?
Yeah, it says documents are being converted, please wait.
Okay, fine.
So where are you sitting?
I am sitting at the console, I'll show you the 1 minute.
So you are in your office
No.
or are you at the venue?
Yes, of course I'm at the venue. Can you see?
You are at the venue. And how many people are there at the venue, attendance?
Yeah, about 50, 60, I guess. They're spread out in the hall.
Right. And then there are other people sort of joining from other places?
Correct.
What?
Mumbai and Edappal in Kerala. I will just show
Okay.
you. Mumbai have turned their camera because I don't think there's anybody in the 1 minute. All right. I think you must be seeing 4 pictures. Yourself, myself, Edappal, and there's a whitish kind of thing that is Mumbai.
Okay. So I don't think she has got any of the. Now it says an error in document conversion.
Oh, maybe you'll have to do it again. Just make sure that the
Okay,
PowerPoint opens
so-
up first correctly,
Yeah.
and then you can close it and then load the document here. Try doing it once more, it should be okay. Is this the same thing that
Yeah.
you tried doing yesterday when you tested?
No, this is bigger.
Okay, fine. Is it opening well in your PowerPoint?
Yes.
Okay. Just do it once again, sir. It'll be fine.
Yeah.
I can see something maternal fetal, but
You can see?
No.
Now it's come up. Yes.
Okay. 1 moment. I think it's coming.
It's come up.
1
Yeah.
minute. I am not able to see still. 1 second. Probably my end it's still downloading. Is it on your first slide?
Yeah, it is. Now it says, do you want to save the file in the list?
Yeah, choice is yours. If you don't want to, you can take it off.
So we'll just say,
You can
okay.
say no or yes. Okay, I think it's coming up. Maternal nutrition, fetal growth, and risk of NCDs in India. DOHAD, correct?
Yes.
All right, sir.
Yeah.
Can you just move a couple of slides for me, just to cross check? The page, left and right arrow. Super. Diabetes, the dogma, susceptibility. Okay, fine, sir.
Yeah.
You can go back to your first slide. All right. So I think we are good to go, Dr. Yagnik.
Yeah.
All right. Fine. So they'll be back soon from coffee.
Yeah. कॅन्टीन हो एक काम करतोस का आपल्या कॅन्टीनला फोन कर आपण पण कॉफी पिऊया हो आज सविता पण आहे ती तिचं ट्रायलचं काम करते
Hello, Mumbai.
हा
Mumbai.
अच्छा.
Can somebody talk to me from Mumbai?
Yeah, we are here.
Okay. I can see your camera is covered, but you're able to hear us and see us there, right?
Yes, yes, yes. I'm able to see you.
All right. Neha?
Yes.
Dr. Revati wants to know if anybody, any doctor or anyone's interested in participating in the panel discussion later from Mumbai. You have the agenda with you?
Actually, as of now, all the doctors have not arrived. So, once they arrive, I can let you know. But as of now, no doctors have not arrived. All the doctors that we're expecting.
All right. Okay. Okay. Neha, if you have the agenda, you can make an announcement, if someone's interesting when Dr. Prakash Mehta is moderating on the subject of placental dysfunction and multiple pregnancy. If someone's interested in joining the panel, they're most welcome.
Okay. I'll let you know.
Yeah, and that's going to be in real time.
Okay. पहिलं बँगलोर आहे दुसरं केरळ आहे आता ब्रेक आहे ना बँगलोरचे खूपच आहे तिथे तरी मला 15 तरी आहे केरळची ते विचारतात
कोण कोण येतात रोहन आला का मीना
We need some people. We need some. Those people are all standing outside. For whom? Which was the, huh? There is proteinase. Proteinase deficiency is there. She's thrombophilic. You say by the time she came, next day she came with a patient. The patient didn't come on time. Come, Ricky. Come this side, please. Everybody come this side.
To do the introduction. Dr. Sunita. Dr. Sunita.
Good morning, Dr. Yagnik. This is Dr. Prakash
Hello,
Mehta.
good morning.
And
How
we
are
are
you?
we are very glad that you have taken some time off on a Sunday morning to be with us. And
Yes.
we are sorry that we have to keep you waiting for some time. We already have Kerala joined us, and Mumbai is also joining
Right.
us. So we have
Okay.
a kind of a multiple satellite centers, and I'm sure everybody will
Yeah.
be greatly benefited by your knowledge. So
Okay, thank you.
we now introduce Dr. Yagnik.
Good morning, everybody. It gives me immense pleasure to invite Professor Yagnik Chittaranjan S. He is the Director, Diabetes Unit, King Edward Memorial Hospital and Research Center, Pune, India. He completed his MBBS and Masters from BJ Medical College, Pune. He is the founder member and vice president of SNEHA, India, and the founder member International DOHAD Society. He is a recipient of Helmut Mennert Award of International Diabetes Federation, David Barker Medal of the International Diabetes Society, and has also won the Outstanding Investigator Award of the World India Diabetes Foundation. He is well known for his description of the thin fat Indian. He has specialized in intrauterine programming of diabetes and has demonstrated a possible role for maternal micronutrient nutrition in its etiology. Welcome, Professor Yagnik. Over to you, sir.
Thank you, Prakash. Thank you, Revati. And though I have said the title was mentioned as micronutrients, I have made it slightly broader. I'm going to talk about maternal nutrition, fetal growth, and how it is related to the risk of non-communicable diseases in later life. This is the paradigm of the new branch in medicine, which we call DOHAD, Developmental Origins of Health and Disease. And I run this diabetes unit in KEM Hospital. It's the only diabetes unit in the world which has mother and baby as the logo. And that's because of our belief, research, and contribution in this field. As she said, I am a diabetologist, so I'm going to build a story around diabetes. As you must have all read in your textbooks as students, and certainly I did, diabetes, the dogma is that the susceptibility is genetic. And if it's genetic, then we assume it's non-modifiable. And then there are precipitating factors which are predominantly obesogenic, which contains either bad diet, physical inactivity, mental stress, a number of other factors, but basically they act on the genetic susceptibility and produce the phenotype which we call diabetes. The diabetes prevention trials which have been done in last 15-20 years have all accepted that the susceptibility being genetic is non-modifiable, and therefore they have concentrated on reducing the precipitating factors. So that the motto of all the trials is basically to eat less and walk more. Now this has produced some benefits, but it also has not dealt with many of the problems. That is because we are treating only the precipitating factors and leaving the susceptibility untouched. Also, we involve people who are adults, who are obese, and who are impaired glucose tolerant in these trials. Therefore, these are more or less end-stage conditions. And given that the average age of people in these trials is above 50 years, they are mostly post-reproductive. So even if there is benefit, it doesn't reach the next generation. So I have researched for last 25-30 years to see is there any non-genetic modifiable susceptibility to diabetes and other non-communicable disease. And whenever you talk of contribution of genetics and non-genetic factors, we usually go to the model of monozygotic twins and see how many of them are discordant for the outcome we are looking for, in this case diabetes. And very interestingly, a large study was done on European twins from a group in Denmark, and they showed that the smaller of the monozygotic twin had higher risk of diabetes. And this was actually a great finding. If you were born small and you were a monozygotic twin, you were more likely to have diabetes than the twin which is bigger than you, which indirectly told us that intrauterine nutrition also has an effect on the risk of diabetes. And before that time, and actually when I was a student, there were very interesting papers published from Europe and US. On the left-hand side, you can see an undernourished mother and a young baby and a young girl. This is a story of so-called Dutch winter hunger. Towards the end of the Second World War, Germans cut off the food supply to Western Holland, and people had to live on a ration of 600 calories a day. And mothers who were pregnant, they also were fed 600 calories a day. So in a way, their children suffered what was called intrauterine hunger or intrauterine famine. These children have been followed up, and they have given us remarkable, interesting information on risk of various conditions. What I've shown here in the figure, that the red line shows the risk of obesity, and it shows that if the child was in the mother's womb during the first 2 trimesters of pregnancy when the Dutch winter hunger happened, that child had increased risk of obesity in later life. So intrauterine undernutrition in first half of pregnancy increased the risk. And interestingly, intrauterine undernutrition in the second half of pregnancy, in the 3rd trimester, reduced the risk of obesity. suggesting there were windows of opportunity during intrauterine life when mother's nutrition influenced the risk of the babies in the future. And at the same time, in US, there were other studies in diabetic pregnancies which showed that if mother's glucose was high in pregnancy, then again the child's risk of diabetes was increased over and above the genetic factors. So we had these two quite interesting findings, undernutrition in the growing sort of fetus and overnutrition of growing fetus increase the risk of diabetes. And this was really sort of nailed down when David Barker came up with his ideas and papers. And the slide here shows that the risk of diabetes in England in people who were born around 1930 was inversely related to birth weight. That means if you had higher birth weight, risk of diabetes in later life was reduced. And on the other hand, if you are born small, your risk was quite high. And as you know, India is world's leading capital of low birth weight babies. So it was very relevant to us. And all this started actually a new idea in medicine, which is what we now call DOHAD, Developmental Origins of Health and Disease. And I am always reminded of this sentence which was said by a Danish philosopher that life can only be understood backwards. It's true for all of us. When we think of something, then it starts going back and we start understanding our present situation much better when we think about our past life. And what David Barker's idea said was that what had happened in your past was influencing your current and future risk of non-communicable disease. And he concentrated on pregnancy, and that's how we now call pregnancy as an experience for the two. In general, we treat mother. Maternal fetal medicine now also incorporates fetus in the treatment, and therefore you are very aware and in line with this thought that pregnancy is the experience for the two. I'm going to show you one more slide which is even more interesting, that it can be an experience for the three. I don't know how many of you would have thought of this. This is a woman who is pregnant with a female child. And as you know, a female child is born with all the ova in the ovary at birth. In other words, her next generation develops along with this girl when she is growing in mother's womb. So in a female pregnancy, it's an experience for the three, and therefore there is an enormous opportunity to influence the life force and the susceptibility from various disorders in a female pregnancy if we improve the health of the mother. So this is quite an interesting thought. This picture is from the article which David Barker wrote, and after that he passed away. So this is the last paper he wrote in Nature. And all this led to, like say, concepts which were well known to the developing biologists or developmental biologists, but they are now come in clinical practice. And therefore we talk of plasticity, which is a very popular word in regenerative medicine, programming, which is a word introduced by Alan Lucas and David Barker, and teratogenesis, which you all know about. Plasticity refers to the phenomenon of freedom of growth and development for a growing system, and it assumes that the environment is plentiful, so that there is no restriction of growth. If there is a restriction of plasticity, we say it's programming. In programming, we suggest that a adverse sort of environment in utero, whether it's nutritional or something else, restricts the growth potential of the baby, and that information remains with the baby for the rest of the life and in turn increases the risk of certain disorders. Teratogenesis is something similar but is structurally a gross abnormality. For example, a neural tube defect. A nutritional deficiency in the mother permanently affects the development of the growing neural tube and leaves the baby with a permanent disability. So it's in a way similar to programming. The windows of vulnerability for programming, and therefore they are also the opportunity windows for intervention, are many. But the best known and perhaps the most important is pre and periconceptional period. And as you know more than I do, majority of pregnancies in the world are not planned, and therefore pre and periconceptional periods are only theoretical concepts if that woman comes to a doctor or to a system after she knows she is pregnant. And therefore, this then goes in the realm of public health. And what we know today is that this periconceptional programming is heavily based on epigenetic mechanisms, but that's also partly influenced by genetic factors. So there are genetic and epigenetic mechanisms, which again we will see. These are some of the epigenetic mechanisms which you must have heard of in various fora. One is called DNA methylation, where there is addition of methyl group to some of the bases in DNA, and it changes the structure of DNA so that certain genes cannot be expressed if they are methylated. So it's a way of silencing your genes. Demethylation, on the other hand, removes that silencing so that gene can be expressed. Similarly, changes in the histone proteins, which are part of the nucleosome, that also opens up DNA for transcription and therefore either allows the genes to express or not allow the genes to express. And third one is a new category of molecules called miRNAs, which many times inhibit expression of different genes and therefore regulate expression of that particular message. I'm sure there are many more mechanisms which we'll learn over years, but these are the three currently well-known mechanisms, and I think you are going to hear more and more of it in various pregnancy complications also. Some of the drivers of these epigenetic changes are commonly known items which we know influence the outcomes in pregnancy. So for example, nutrition. In this, a very prominent nutrition which affects epigenetic change is methyl donors in the diet, because I told you DNA methylation is a major mechanism of programming, and that includes vitamin B12, folate, choline, betaine, and number of other molecules which can donate a methyl group. Similarly, vitamin D, which is active on genes, and vitamin A, which is active on genes, and omega-3 and omega-6 fatty acids, which are active on genes, they can all cause epigenetic changes in the growing fetus. So now there is a lot of excitement that what we otherwise just considered as nutrition and thought it probably regulated enzymes, we now know that that can influence the DNA and therefore expression of genes, and therefore can have profound effects on the fetal development and its future health. Similarly, abnormal levels of glucose and fatty acids, as in diabetes and obesity, maternal stress, a number of atmospheric pollutants, so-called endocrine disruptors, ambient temperature itself, and very importantly, as we now know, microbiome of the mother can influence epigenetic changes in the baby. So suddenly a new area has now opened up, which I think will be intensively investigated over many years, and we will learn quite interesting findings. Only last week, Lancet has published this series, and it's called a series, a consultation on preconception health. And there are 3 papers in this. And if you look carefully, I am author on 2 of these. So one of the authors only. And this is first time that a major journal and a very reputed journal has now focused on preconceptional health for improving the health of the society. And as practicing gynecologists and obstetricians, you are going to be really interested in improving preconceptional health of young girls, so that the outcome not only in the pregnancy itself, but also in the long run for the baby over its rest of the life will be influenced. So I would strongly recommend to you, go to Lancet, open it last week's, and download these 3 papers and read them at your leisure. They are extremely well written by experts. Lot of information. Please read it. And this is a cartoon which shows what happens to DNA methylation around meiosis, which happens in the ovum and spermatozoa, and what happens after conception. So that you perhaps know that within 48 hours of conception, all the methyl marks on the DNA are completely wiped out, and within next 24 hours they are re-established. So that mother's nutrition and a whole lot of other factors which we said influence epigenetics, if they are acting around this periconceptional period, influence the re-establishment of methylation in the DNA and therefore alter the health and the future of the baby. So now for diabetes and practically for all other non-communicable diseases, we have an additional modifiable susceptibility in the equation, and that's the epigenetic rather than genetic influence. And this is a great excitement of last couple of decades, that we can influence the susceptibility of the fetus for a whole lot of things by acting appropriately in the windows of opportunity, of which the most important one, as I told you, is periconceptional. Now this is a very interesting figure. Some of you might have seen it before. It is called a cartogram. And cartogram is a world map where size of the country is proportional to the burden of the condition for which it is drawn. So look here on the right side, diabetes cartogram of the world shows India as a very fat country, because burden of diabetes in India is very high. And you look on the left, and India is even fatter, and that is for undernutrition in early life, either low birth weight or undernutrition under 5. And as you know, India produces largest numbers of low birth weight babies in the world. It has the largest number of under 5 undernutrition in the world, and these are indirectly related to various micronutrients and macronutrients in the mother and in the baby. And therefore this figure tells us that 2 conditions, where one is driven by maternal undernutrition and other one is driven by subsequent overnutrition, are very common in India. So it's a paradox. And I have actually liked these 2 figures because that explains a lot of things which we have researched and which I am going to tell you. This is a paper published by Dr. Mohan's group from Madras, where he did survey of diabetes across the country under the ICMR INDIAB study, and the pink bars are the prevalence of diabetes in the lower socioeconomic group, and blue bars are the prevalence in the higher socioeconomic group. And interestingly, in 8 out of 15 states of India, diabetes was found to be higher in the lower socioeconomic groups, which is quite counterintuitive but not unexpected, because that is what happened in Western world for last 50 years. So India is catching up, and it is showing that undernutrition in the lower socioeconomic class might be a risk factor for diabetes in future because of so many reasons. And my department has researched a whole lot of research studies in these areas in last 25 years. This is a summary article which we published from 1987 till 2014. We have done number of studies which have allowed us to look at diabetes in Indians, not only in adults, but in children and in pregnancy, and study the effect of maternal nutrition in pregnancy on future risk of non-communicable diseases. And the flagship study in my unit is called Pune Maternal Nutrition Study, which we did in 6 villages near Vadu, that's Pune. We studied mothers from before they became pregnant. So we went to 6 villages, listed all mothers who were married but not pregnant. There were 2,675 of them. Then we waited for them to become pregnant and studied them intensively in pregnancy for their nutrition, metabolism, father's measurements, and growth of the baby. Then we measured babies in detail at birth, and then every 6 months till 18 years of age. And every 6 years, we do detailed studies for risk of non-communicable disease like diabetes, blood pressure, heart disease, and a number of other things. And we store samples in our freezers, in our biobank, so that we can go back to them and measure various things. And we made some interesting observations along the way. You can see an average mother in our study. This mother is 28 weeks pregnant. She is only 47 kg. But you can see she is carrying 2 pails of water from the village well to her house, and each pail is 15 liters. The 47 kg woman carrying almost 30 liters of water on her head for a couple of kilometers. And then she looks after the family. She cooks for the whole family. She looks after the animals. So enormous energy. Her weight gain in pregnancy was not more than 7.5 kg. And she produced baby, which is next door here. That baby was on average 2.7 kg. But based on my interest in body composition, which is to measure body fat and lean mass, we discovered that this thin baby in India, which is 800 grams lighter than a baby born in Southampton in England, which is 3.5 kg, the Indian baby had more fat in the body compared to the English baby. And this is the famous concept which I developed of a thin fat Indian baby. And the reason is, during development, when the nutritions are allocated to development of lean mass and fat mass, the Indian babies seem to allocate it to development of fat rather than lean. So they look thin, they have less muscle mass, but they have more fat, especially in the abdomen, which we found out by doing a whole body MRI in newborn babies and compared them with MRI of newborn babies in England. And what the figure below that shows you, that 3 compartments of fat in the abdomen in the Indian babies were bigger than the English babies. So quite a remarkable finding. And then we showed that maternal B12, folate, and other nutrients were related to the size of the baby. And what I have shown here is that higher maternal folate concentrations were associated with larger size of the baby. And on the other hand, higher concentrations of homocysteine in the mother were associated with a smaller baby, so that it increased a risk of what we call SGA, small for gestational age baby. And high homocysteine in the mothers in Pune came from considerable B12 deficiency, not folate deficiency. So B12 deficiency drove this high homocysteine, which in turn predicted a smaller size and SGA. In other words, we have described thin fat Indian babies which are more fat, though they are small, and that the growth of the Indian babies is driven quite considerably by maternal micronutrient status. Then we followed up these babies, and when they were 6-year-old, we measured their blood for glucose, insulin, and insulin resistance and other factors. And what we were able to show was that if mothers had low B12 in pregnancy but high folate, then the child was more obese or adipose and it had higher insulin resistance. So this imbalance of low B12 and high folate, which is observed in vegetarian populations, was associated with increased risk of diabetes in the baby because the baby had higher adiposity and higher insulin resistance. Similar findings were confirmed in a cohort in Nepal. When they read our paper, they reanalyzed data, they found similar thing. And when we followed up these children at 18 years of age, we found that low vitamin D in the mother during pregnancy, low B12, and high folate predicted higher adiposity in the baby as a young adult at 18 years of age. Side by side, we have also done neurocognitive tests in these children and shown that low B12 in the mother during pregnancy was associated with impairment of neurocognitive development in the baby. So in other words, B12 is affecting not only the well-known sort of target of B12 like brain, nervous tissue, but also adipose tissue and metabolic pathways. In other words, low B12 is programming the baby for a number of outcomes in later age. And this is because B12 and folate are related or drivers of what is called one-carbon metabolism, which is metabolism of carbon, one carbon, which is methyl group. And what does this methyl group achieve in the metabolism? It impairs DNA synthesis or promotes DNA synthesis depending on the balance. It affects DNA repair. It affects DNA methylation, so epigenetic changes, genome stability, protein synthesis, and number of physiological processes. In other words, this central metabolism of methyl group affects so many processes in the fetus that actually if there is an imbalance or a deficiency, you can face number of problems in the baby. And then we did more molecular studies with help of Dr. Chandak from CCMB. And he and his students showed this brilliant finding that vitamin B12 supplementation influences methylation of genes associated with type 2 diabetes and its intermediate traits. So this is a very exciting paper that B12 can have effects which you might have never suspected actually. It's a very interesting paper. So when these children became 18-year-old and who were born to very undernourished mothers who had a lot of B12 deficiency, a glucose tolerance test revealed very interesting findings. Okay, the table shows here first that almost half of these children are underweight by WHO criteria. That means their body mass index is less than 18.5. Only about 5% are overweight or obese. That means their BMI is more than 25. 10% are stunted. 27% of boys and 8% of girls have higher fasting glucose, what we call impaired fasting glucose. 10% boys and 9% girls have impaired glucose tolerance, which is higher glucose 2 hours after 75 grams of glucose. And 2 girls had diabetes, which we diagnose as a genetic type of diabetes. So we don't include it in the other analysis. But in overall terms, 28.7% of these young people had pre-diabetes. 37% of boys and 18.5% of girls. That's very high prevalence if you understand that half of them were undernourished. So it's a very interesting finding that children born to undernourished mothers have developed a high risk for diabetes as young adults. And this may be driven by undernutrition in utero. On the other hand, given that we have a diabetes sort of unit and I treat diabetic pregnancies, we have also followed more than 200 children born in diabetic pregnancies at an average age in two groups. In one group, the average age was like say below 10 years, so they were 8-year-old. And in the other group, they were more than 10-year-old, average age was 16, 15. So at 15 years of age, when the child was born to diabetic mother, then we compared to the child born not to non-diabetic mothers. The children of diabetic mothers, 5% had already developed diabetes at a mean age of 15. Had a normal glucose tolerance. On the other hand, when we looked at children born to non-diabetic mothers, 20% had pre-diabetes and 80% were normal. So there is a high prevalence of pre-diabetes in our population at young age, but it's twice as common if the mother had diabetes. So you can imagine 2 out of 5 children born to mothers with diabetes at average age of 15 years have either diabetes or pre-diabetes. And therefore, I have developed this concept of dual teratogenesis, that in the villages in India and for last many generations, the major issue was that of undernutrition, undernourished adolescents, undernourished mothers who produced small babies, but they were thin and fat. Having high amount of fat, they were insulin resistant, but their postnatal nutrition was not very, like say, prominent. And therefore, they continued to be thin and fat, insulin resistant, but did not have much diabetes. When they migrate to cities or become more affluent, there is overnutrition and obesity even in the young adults and adolescents, as we see predominantly in the cities, and they get gestational diabetes and produce bigger babies, who in turn are at higher risk of diabetes. So that there is a lot of pre-diabetes and diabetes in our country, given both undernutrition as well as newly sort of discovered overnutrition in the young adults. And this is another figure which I have developed, that if we look at life course, then there is father and mother and they provide the genes, but we have said the epigenome is an important determinant of future phenotype, and that phenotype goes on changing in the childhood, so that ultimately in the adult age we define a disorder like diabetes or whatever. I heard your previous lecture was about preeclampsia, and I am sure preeclampsia in the mother actually can be traced back to her own development, nutrition and growth in utero, because there are already very interesting stories about preeclampsia and hypertension in general being programmed in utero. So it will be quite interesting to do such studies in India. Finally, I am going to tell you about microbiome and how it might affect B12 and the diabesity which we are talking about. And one interesting thing is vitamin B12 is only made in nature by microbes. No other living organism can synthesize B12. So we depend on microbes for providing B12, and given the recent interest in microbes, there are a whole lot of interesting possibilities how they might affect. And this is again a study in collaboration with Dr. Chandak and his students in CCMB, that we have now identified the genes which influence B12 levels in Indians. And to my great surprise, up to 10% of B12 deficiency in our population, we could ascribe to contribution of genetic factors. And in that, one gene which is quite strongly associated with B12 deficiency is FUT. There are 6 genes, 1 to 6. So FUT1 and FUT6 were strongly related. Now what does this FUT do? It actually fucosylates proteins. Fucosyl group is a sugar group, and it helps to add sugar to the protein. And these fucosylated proteins in the intestine allow interaction between microbes and the intestinal wall, so that these microbes can either provide nutrition or take away nutrition from the host. Now why am I telling you all this? Is because we have shown that B12 deficiency in the mother can increase the risk of adiposity and insulin resistance in the child. And we were also wondering why this should be there. And we got the answer when we read a paper published from Denmark. I go to Denmark as a visiting professor of diabetes, and I met this group who published this quite interesting paper. They also really didn't know what exactly it meant, and together we interpreted it. They showed that FUT genes in the Danish people actually are able to influence the risk of obesity in the Danish people. So that if you have a FUT gene SNP or an abnormality, then your risk of obesity increases. And this was then suddenly related to B12. Because as I told you, fucosylation of intestinal proteins is actually a mechanism whereby B12 might influence the mechanism. So we are now working on all these complex mechanisms of genetics, nutrition in the form of B12, and how it might epigenetically change the susceptibility to adiposity and insulin resistance. So I think within a couple of years, we are going to publish something quite interesting. It takes a lot of time and efforts to do this. And as you know, a pregnant mother faces microbiome everywhere. So you have probably heard of course, vaginal microbiome, which of course is transferred to the baby during a normal delivery, and therefore cesarean section babies have a different type of microbiome. Microbes cross the placenta, therefore mother to fetal transfer occurs throughout pregnancy. Mother's oral microbiome has been shown to influence fetal growth. Mother's gut microbiome has been shown to influence fetal growth and development. And the breast milk carries various microorganisms, and the skin around the areola also has a lot of bacterial growth. So baby is being fed a lot of microbiomes, and that is how baby's microbiome is established. And depending on mother's nutrition, hygiene, and her previous experiences, mother's microbiome changes in all different places and indirectly influences the future of the baby. So that's a new interesting concept. Now, what are we doing about all these findings which we have produced in research? And the Pune research drove a trial in Mumbai, which was done by Dr. Ramesh Poddar and Caroline Fall, is our collaborator. And from Pune, we had described in the village women that consumption of green leafy vegetables, milk, and fruit promoted fetal growth. So they created a samosa where they put green leafy vegetable powder, milk powder, and fruit powder, and fed it to women from before they became pregnant and during pregnancy. So it's a preconceptional and post-conceptional trial. And what they were able to show was that the birth weight of the baby increased in the group which was fed these high micronutrient samosas. These children are being followed up, and we will see whether supplementing these micronutrients as food based on the findings in Pune trial are able to influence the risk of obesity and diabetes in this child. These children are now 7-year-old and studies are already happening there. And in Pune, we have started a trial which we call Pune Rural Intervention in Young Adolescents, PRIA, where we are supplementing B12 and other micronutrients in the children born in the Pune maternal nutrition study. So they are F1 generation. And we will look at F2 generation for their thin fat phenotype, their cord blood concentrations, and a whole lot of genetic and epigenetic markers in the mother and baby, not only in the cord blood, but also in the microbiome of the mother, for which we obtain samples from mother's vagina, from her stool, and from her areolar skin. A whole lot of exciting things are going to come out of it, again, as I said, in next 2 years. So I'm going to summarize what I have told you. I have told you that unlike the conventional idea that the the susceptibility to diabetes is genetic and therefore non-modifiable, we have now described the non-genetic susceptibility to both adiposity and diabetes. And this is epigenetic. The major window is periconceptional and in pregnancy, and that is why your role in this phenomenon is going to be quite crucial. It's a new thought that a gynecologist and obstetrician is going to influence the risk of diabetes in the community. Maternal nutrition, her metabolism, her microbiomes, her stress, all play on the epigenome of the baby. And we are understanding this novel epigenetic intergenerational transfer by doing number of molecular biology studies. When we talk of prevention of diabetes, as I said, the current idea usually is to act in the adult life, but we now know that prevention will of course have to start early, and because the programming mechanisms might have become established, it might take even a few generations to revert this programming, which is what we have seen in the animal work. And therefore, I usually say that it's never too early and never too late. So we can start today in anyone who is in front of you, and we can influence the risk of diabetes for not only 2, sometimes up to 3 generations if that mother is pregnant with a female child. And I'm going to say that I have been actually collaborating with a whole lot of people, not only in India, but also abroad. And we have to acknowledge their great interactions and great transfer of knowledge that has happened. And the participants in our studies who have actually allowed us to set up some of the best birth cohorts in the world. You will be surprised to see that in the birth cohorts up to 18 years of age, we have up to 95% follow-up, which is one of the best in the world. And this is actually because of the role of our field workers who are part of the villages where we do the studies, and they have driven this high follow-up, and therefore we are very, confident of our findings. So thank you for patient listening. I'm sure this is somewhat different than what you listen every day in your gynec obstetrics series. And if you have any comments or queries, let's discuss them. Thank you.
Questions?
Thank you, Dr. Chittaranjan. That was too good. I wanted to know, a few years back, vitamin D was deficiency had become the rage. Is it vitamin B12's turn now?
Okay, I think we have multiple micronutrient deficiencies, and depending on the investigators' interest, they find one or the other. Vitamin D has been low in Indian populations across the country, despite the high sunlight, and there might be various reasons for that. And as I said, vitamin D acts on the genome, so it's a strong epigenetic modulator. So yes, I mean, this is not to ignore vitamin D at all, but more detailed studies need to be seen or need to be done to see what's the mechanism of action in influencing the risk to the baby. A randomized control trial was done in Southampton in David Barker's unit of feeding vitamin D to pregnant women. And what they found was, in the preliminary analysis at birth, they found that if women were supplemented with vitamin D in the winter months, which is the time when they are low in England, the growth of the fetus, especially the longitudinal growth, the length or the height of the baby, improved. And they are also following up these children to see what will be the long-term benefits on the bone mineral density as well as on the lean mass. So we have to wait for long-term follow-ups. B12 is largely a result of investigation in my unit, and that's probably because we found a population which is very high in B12 deficiency. But there are now number of studies from Western world and in animal field that vitamin B12 and folate have been shown to be very strong determinants of epigenetic potential. And as I said, omega-3 and omega-6 fatty acids are other nutrients which are waiting to be investigated. So I think a lot of exciting studies are going to happen in next few years. It's not to say one or the other. It's ultimately going to be the total nutrition. But now there is increasing realization that micronutrients may be very important. Thank you for that question.
Thank you so much, Dr. Yagnik, for that.
One more question.
Just one thing, I would like to say that Dr. Yagnik has traveled all the way to his workplace on a Sunday to be with us. A big clap for that, please.
Thank you.
Sir, what about the role of folic acid throughout pregnancy? Since nowadays we are giving folic acid throughout pregnancy, do we need to balance it with vitamin B12, vitamin D? Because there are some adverse reports too.
Very relevant question, and thanks again once for asking for that. What I find is in predominantly B12 deficient populations, which is vegetarians and especially in India, if you give too much folic acid, you are creating an iatrogenic imbalance. So that in a B12 deficient population, we are giving a lot of folic acid. When we were students, we knew that in pernicious anemia, you can give folic acid and improve the anemia part of it to an extent, but you cause damage to the developing nerves and the brain. So this was described long time ago. In our studies, we showed that if mothers have low B12 and high folate, it increases their risk of diabetes in future. There are studies from US which have shown supplementing large dose of folic acid in people who have B12 deficiency also produces peripheral neuropathy. That means damage to the nerves. So I think it would be very sensible to include B12 as part of your treatment when you are treating with folic acid, either periconceptionally or later in the pregnancy. And another important issue is in rest of the world, usually the upper limit of folic acid which is given every day is 1 milligram. The tablet which we have on market is 5 milligrams. And many times people think more the better, so they give 2 or 3 tablets. So that in a B12 deficient population, if we give very large doses of folic acid, there is a real danger of doing some damage. And therefore, I would suggest to you that if you are thinking of giving folic acid, don't give too much dose. Give within physiological described doses and cover that with B12, because in India B12 deficiency is quite common. And I think, thanks for asking that question. This would be a very important message for all the practicing obstetricians and gynecologists.
Sir, but don't you think that instead of giving tablet, we gave folic acid, then we found B12 deficiency. Now we'll give B12 and we'll find maybe B6 deficiency. Don't you think it would be
Yes.
much better to give a proper nutrition as such instead of
Absolutely.
tablets?
Absolutely. I mean, see what happens, tablets are usually in the realm of individual medicine, which is what doctors practice across the table. What we really need to do is to improve the nutrition of the population. And that's why somewhere in the initial comments I said it is a public health issue. And therefore, public health wise, when we improve the nutrition of the adolescents, we are going to see much better effects. And I can tell you, in the Pune maternal nutrition study, we are now finding that the daughters in the F1 generation are 5 centimeters taller than their mothers. They are 5 kg heavier than what their mothers were at the beginning of pregnancy. So things are improving in the population. But then when we look at their micronutrient nutrition, we are still finding a lot of deficiencies. And therefore now the public health approach also needs to take into account to increase the food items which are rich in micronutrients. And the pattern of deficiency might vary from place to place. Like say in my place, B12 deficiency is quite common. In Kerala, I am sure it's not B12 deficiency, it's folate deficiency which is common. And in some other place, it will be something else. And therefore, we need some driving research. But overall need is to improve the health and nutrition of the adolescent girls so that we pass on the benefit to the next generation. So your comment is very well taken. I entirely agree with it. And improving nutrition is the bottom line. Yes.
Dr. Padmini had a doubt. Says a lot of us keep giving dabbas of protein to the patients.
Yes.
And all kinds of nutrients in it. Is it worthwhile?
I have serious doubts about it, except in patients who are seriously protein deficient. I think, as you mentioned, what we really need is a balanced diet, which is, like say, consumed from before conception, and a proper understanding of what is relevant in that population. All these dibbas and other things are again, like say, a manifestation of a need for the doctor to act. Because when a patient comes to you, you must
have to give
prescribe
something.
something. Yeah. And then we see the last MR who visited us, that product usually is fresh in your mind, so we used to prescribe. So I would say we need to actually sit down, think more widely and in more purposeful manner, and actually think about improving the nutrition of the young girls.
Any questions from Kerala before we end the session? Any question from Kerala? Okay.
I would like to
Thank you,
Professor.
Thank you, Dr. Yagnik, for that enlightening session. This is Revati. I've been troubling you with all the mails, called you at 8 o'clock in the night for the confirmation. But I think it was really worth all. Yes. It was really enlightening, and we were, we really enjoyed the Indian experience, which is so important for us to actually take it forward. I also have Dr. Jyotika Desai here, who has been the past president of the Bangalore Society of Obstetrics and Gynecology. She wants to have a word with you, sir.
So it would be a pleasure if you would come to the AICOG in 2019 in January. We'll send you a formal invite.
Please do, and if I am not committed, I'll definitely come.
Between 8th and 12th of Jan, 2019.
Okay, I'll look up my diary, send me the invitation. If possible, I'll definitely come.
Thank you so much.
Thank you.
We request the president, Dr. Prakash Mehta, to do the honors, a virtual honors.
All right. Thank you, and look forward to seeing you again. if possible, at the AICOG. Thank you once again.
Beautiful elephant, a local product.
This is coming from Karnataka to you. It's going to be FedExed
Okay.
to your address, sir.
Thank you very much, and thank you for listening patiently.
And it's a
Thanks.
fat elephant, sir.
Okay, right. Thank you. And let's thank Prakash who made the presentation. Thanks, Prakash.
Thank you, Professor Yagnik, once again. Thank you from all of us here at Bangalore.
All right. See you soon.
I think now we'll quickly move on to the inauguration because we are running short of time. I call upon our President, Dr. Prakash Mehta, sir, and Dr. Revati for doing the inaugural onto the stage.
I would also like to invite Dr. Jyotika Desai, Dr. Padmini Prasad. Later. Bunny, madam, please. All our EC members of SMFMI, please come over to the stage. Yeah. Yeah, I will give the mic to you.
We'll just finish it in a minute. Thank you all for this wonderful meeting that we have had. I'll be failing in my duty if I fail to thank Jain Hospital for providing us with all kind of amenities. You can see the people from Jain Hospital working from yesterday non-stop, and although today is a holiday, each of the department, one representative has been here. And believe me, this hall was not ready. We were supposed to go into that hall, but because that hall couldn't get ready, this hall was got ready within the last 1 week. So I take this opportunity to thank the hospital for all the support they have given to us. And I have to thank the entire team over here. Revati, who has, I think, almost gone crazy by the time the meeting became a reality. Sunita, Sushma, Smita, Harini, Hema, Shruti. So all of you for doing an excellent job. And of course, I take this opportunity to also thank all the pharma companies, because this kind of a network transmission is not cheap. It's very expensive, and the most expensive person in this hall is there. So, I mean, thanks to their support that we have been able to do this really well. And next, it has come up he's done a very good job. Prakash has done an excellent job. Okay, so without wasting any further time, I think we'll go in for the next program.
After that really quick inauguration, we'll move on to the next session, which is a panel on placental dysfunction and multiple pregnancy. I call upon our dear Dr. Prakash Mehta to moderate the session. Can we have Dr. Shrija from Idapal? Are you there? We can't hear you.
The panelists are Dr. Srividya, the fetal medicine consultant from Milan, and Dr. Revati S. Rajan, consultant medical director in Mirror Health, Bangalore. We welcome you on the stage. Dr. Shrija, please join us.
Am I audible to you?
Yeah, I'll take this. Now I can vote from here. Somebody from Mumbai wanted to join. Have they come in or not yet?
Is Mumbai in?
It's okay. All right, we'll have to keep to time, Prakash. Make sure that, because by 2 o'clock we have to be in touch with Spain. So we need to be in time. You please let me know at least 5 minutes before. I wouldn't mind cutting down. Yeah. Can we go on a show, please? All right, now twin pregnancies have always meant double trouble. And we know that placental dysfunction is very important in a singleton pregnancy. Does this kind of placental dysfunction occur in a twin or a higher multiple gestation? If so, is this dysfunction more as compared to singleton or less than in a singleton? Or 2 babies means double, 3 babies mean triple the amount of dysfunction? To add to the confusion, we have the zygosity of the twin pregnancies, we have the chorionicity of the twin pregnancies, and whether each of these could cause some kind of placental dysfunction is what we'll try to elicit today. Okay, now since the time of Cosmos and Damian, these are the twin brothers which represent medicine and surgery, legends have attributed both magic and even danger to the twins in health and disease. Now, multiple pregnancies we know are a growing challenge for 2 reasons. Number 1, the increase in the maternal age. We have a higher incidence of twin pregnancy, especially above the age of 35 or 40 years. And the use of ART with multiple embryo transfers have also increased multiple pregnancies. Now, why are we worried about multiple gestation? Dr. Revati, why are we worried about multiple gestation? What is the kind of placental dysfunction, or what do you think is happening in this multiple gestation that we need to take it as a separate group apart from singletons?
So first of all, we'll have to understand that there could be a situation where there is there could be 1 or 2 fetuses who are sharing the same placenta. There could be a vascular insufficiency which could exist because of sharing the common blood supply, and this could probably lead to several problems later. So basically it's this uterus which is there, and you have 2 fetuses and the placenta, and there could be vascular insufficiency which could later predispose to several problems.
Yeah. So we know that both the mother and the baby both are at increased danger in a twin gestation. Now look at this patient. She's a gravida 3, abortion 2, with 31 plus 1 weeks of gestation, elderly gravida with bad obstetric history, preterm twin, DCDA. She's B negative, she's hypothyroid. There's a cervical stitch in situ, and there is a severe preeclampsia with massive abruption along with HELLP syndrome, IUD of one of the babies, and in breech presentation. So this is how most of the terrible multiple pregnancies present. Or look at this other one, where you have a primary gravida with again a DCDA twin with severe preeclampsia with IUGR in one of the babies and absent in diastolic flow. Now, lot of dilemmas as to why the placental dysfunction is occurring in these patients. What can we do about what is happening? So how does this placental dysfunction occur? If Dr. Shrija would like to answer, I would like her to answer this question.
Sir, am I audible?
Yes, yes, definitely.
Okay. So when we talk about placental dysfunction, the difference between a monochorionic placentation and a dichorionic placentation seems to be important. Because if you're dealing with two placentae, it could be that, for example, if it's a dichorionic placenta, one of the placentae could be defective, starting from its implantation site. It could be a differing growth potential. They could be discordant for an anomaly. While we deal with a monochorionic placenta, the shared territory of that one of the twins could be small, or there could be certain placental abnormalities like velamentous cord insertion, or certain placental pathologies which are usually microscopic, like an avascular predominance of avascular villi. So whether it is dichorionic or monochorionic, dysfunction in the placenta usually manifests with changes in either the biometry or with or without biometry changes, manifested as only the Doppler changes.
Absolutely. So placental ischemia, which occurs in a singleton, could occur in a much bigger way with much different reasons in a twin. Yes,
so could I just coin the term sharing with deprivation actually? Sharing and anastomosis leading to
think Reti
deprivation.
has come up with a very good phrase. Sharing with deprivation is what we are worried about. Not moving. Slideshow you make it. Okay. Now, there are various sites of action. We'll not go into the details of it. It's moving? No. Okay. What are the factors that are involved in placental dysfunction? Of course, Dr. Shrija told us some of the factors. Anything more to add? What about you, Srividya?
Here the placental dysfunction, apart from what Dr. Shrija said, is like maternal age, because we know that majority of the twin conception is happening in the advanced maternal age, and also associated with other infertility factors. So definitely there will be background imbalance which is already happening. So yes, maternal factors along with the type of twinning, as Dr. Shrija described very aptly, the cord insertion site, and also the anastomosis which is present in a monochorionic twinning.
So could we actually summarize?
Yes.
Is there something that Idapal wants to say? Okay, we just wanted to probably
Okay, so now
summarize.
what are the demographic factors, the dietary factors, the social, physical factors which act on a singleton, possibly act in a much bigger way with a twin gestation?
So there's an a priori risk which gets worsened because of a plural gestation, which is mostly attributable to endothelial damage.
What are the outcomes of placental dysfunction? Ultimately, what is the end result? Of course, we have gone through it, but let us just quickly recapitulate. What are the outcomes of placental dysfunction?
With respect to the mother, you have preeclampsia, you have fetal growth. Most importantly in twins, it's fetal growth restriction. You have it in combination. You could probably call it acute and chronic. And if it's something that's persisting from a long time because of endothelial damage, it's usually preeclampsia, preterm delivery, fetal growth restriction.
Yeah.
If
And
it's
not to
acute,
forget-
it's abruption.
Absolutely.
IUFT.
Abruption is also one of the important problems that occurs in a twin gestation. And the early onset preeclampsias are much more common in a twin gestation as compared to singletons. How common is preeclampsia in multiple gestation as compared to a singleton? Dr. Shrija, would you like to take that question? How common is PE?
Is Dr. Shrija in?
Hello. Yeah, of course, in multiple gestation, preeclampsia is much more common, and it is the early onset preeclampsia which predominates and the preeclampsia which would progress to HELLP syndrome much earlier.
Okay.
So there's another thing that I would probably want to add is it's very, very difficult to actually predict preeclampsia in twins. We were talking about the biomarkers. It looks more simple to do it in a singleton pregnancy because we don't really know which placenta is actually contributing to what biomarker. So it is again complicated by the fact that it could be atypical, it could be early onset, it could be very fast and progressive, and it could be
Absolutely.
disastrous.
So preeclampsia is roughly 3 times more common in a twin pregnancy as compared to singleton. As Dr. Shrija said, it develops earlier, it's more severe, and there is an increased chance of abruption in a twin gestation as compared to singleton with PE. It'll come. All right, so these are the same articles saying that that would be possible. Now, I think, did we go back?
Yes, so you finished the incidence
Okay.
of preeclampsia.
Now, why does this happen? Why does preeclampsia become more in a twin gestation? There are basically 2 theories. One says that there is an increased immunologic response because of the twin placenta. The other says that there is a genomic incompatibility theory. We all know, ultimately from morning we have been hearing how genes are cause of everything, starting from diabetes to malnutrition. So ultimately, even a genetic incompatibility could be a possibility. Okay, now there could be an increased risk of PE because of the placental mass hypothesis. Now there was some problem when we say that there is a genetic abnormality which is causing preeclampsia. Then when you have a dizygotic twin gestation where there are 2 different gene pools, as compared to monozygotic twins where there is a single gene pool, the incidence should have been different, but it has not been found to be different. So whether there is 1 genomic pool inside the uterus or whether there is 2 genomic pool inside the uterus, the outcome for PE is the same. So the next theory that came in is our olden days theory, whether the placental mass is influencing. And we all know that twins means a bigger placenta, a larger placental surface, and that also could be a cause. What happens?
So you've also put in a very important point there, sir. Actually, it's not the mass of the placenta, it's the perfusion which matters, and that's what actually gets the factors high.
Absolutely, yeah. Why are we going back? Are there any specific prenatal risk factors for hypertensive disorders in twin pregnancies?
Which are only specific to twins? All the pre-existing risk factors like obesity, metabolic syndrome.
Absolutely, the common factors which are there for a primary are there.
The monochorionic trend.
Apart from that, any maternal risk
Specific.
factors or the social risk factors is what we are talking about.
The malnutrition part.
Are there any other factors? Because most of the twin pregnancies are due to ART. Anything in ART that plays a role? Anything in ART? I think it's just going topsy-turvy.
No, you're pressing it. So you're holding it the other way.
Oh, okay. That's why I'm going back.
Yeah.
I was wondering why I'm going back.
You're holding it reverse.
Okay. So all the other factors are there, but there are certain factors. If you have a patient with egg donation or you have a patient with pre-pregnancy obesity, the chances of preeclampsia increases.
So that could also be because of you could have the same factor even in a singleton pregnancy, right?
Yes, but here because you have got multiple eggs being put in,
So
the chances increases
mean
a
to
little
say-
more.
Okay.
Absolutely. Now, does primary parity increase risk compared with multipara in twins? You understand what I'm asking? If there are multipara lady with twins, and if there is a primipara with twins, who has more risk and why?
Primipara.
Okay.
Because she's obviously not, just like what we were talking about, the
No.
genetic pool, she's not exposed to the.
No, those are the common factors that would occur even in a singleton.
No, she's twins, right? So it gets
Yeah, now
worse.
she is with twins. So what are the possible factors? What are the possible factors? Okay, one of them could be that the high rate of underlying infertility and underlying disease like chronic hypertension, which increases more with the twin gestation. Okay,
So, but how would parity come into picture when there's chronic hypertension?
because generally when she, not chronic hypertension, we are talking of a patient who has got pregnant through ART. Possibly she's older, possibly she's diabetic,
Pre-existing
possibly
risk
she's
factors.
hypertensive. So her chance of having a much more. Now supposing you have a multiparous lady, she would be already having 2 babies and then she conceives a twin.
So there is already an existent risk factor
Absolutely.
which gets worse.
Now twins can be due to ART. Okay, does age of the couple play a role in placental dysfunction? How does it play?
Yes, definitely age does play. Whether it's a singleton or even in twins, age does play a role in it. And as all of us know, age as a risk factor not only in dysfunction but also other chromosomal issues also will be there. Even the sperm genetic matter also plays a role here at this stage.
Now we have been talking of epigenetics. Epigenetics is something that is going to stay with us for a long, long time. And once the epigenetics factors are added, there is a reduced placental efficiency, reduced placental dysfunction, and therefore you have an increased risk of both FGR and stillbirth. Okay. Maternal aging is associated with uteroplacental dysfunction, that we all know. Now, placentas from women with advanced maternal age showed an increase in syncytial nuclear aggregate and decreased proliferation and had increased amino acid transporter activity. Now, I can't simplify into normal English any more than that. We will have to understand each of those words. And advanced maternal age was also associated with lower maternal serum PAP-A and SFLT and an higher PLGF-SFLT ratio. Lot of experiments was done in an AMA mice, and it was found that they had fewer pups, more later fetal deaths, reduced fetal weight, increased placental weight, and reduced fetal placental weight ratio compared to the younger mice, which were 8 to 12 weeks. In mice, by the time they become 38 weeks, they are old. Now, does the adverse perinatal outcome increase because of the presence of PE? Because for us, ultimately,
Yes.
perinatal outcome is the most important.
This is in twins, yes, because we know that it's usually early onset preeclampsia which happens in twins. And obviously the twins weigh, as it is, they weigh lesser when compared to singleton pregnancies. So carrying them to viability at 28 weeks may not really mean the exact birth weights that we are actually targeting. And it could be battling with other risk factors like bad endothelium and other complications like diabetes and things like that, which may get aggravated because of twins. So these things can contribute to worsening preeclampsia and an early delivery. So
Right. At the same time, there are articles which have started appearing. This is from October 2016, which says that it could be mainly due to inability of the environment to meet the nutritional needs in multiple pregnancy rather than an ischemic placenta. So we heard a lot about nutrition just sometimes back. In a twin pregnancy, that is why the nutrition becomes more important. Does the risk of PE differ because of chorionicity?
The incidence of preeclampsia comparatively they say slightly higher in monochorionic, but however there is no much of difference. It's not been put across in the papers everywhere, but few articles does say that.
The DC is higher or MC is higher?
MC. Few articles do say MC.
Yes, but what could be the reason for MC being higher?
The reason which they have mentioned, especially for development of preeclampsia for a MC, is that probability that the sharing also and also the large placenta which is there. So that could be one of the reason is what they have mentioned, but rest of the articles say it's the same.
Yeah, actually what happens is if you take milder preeclampsia, it is more common in a DCDA twin. whereas the severe kind of preeclampsias are more common in a monochorionic twin.
So it could also be incidental associations, no,
It
sir?
could be.
It has to be established because it all depends on the vascular perfusion, basically.
Absolutely. Now, what has been postulated is that the immunocompatibility between the mother and the fetus contributes to the pathogenesis of PE. We know that sentence.
Yes.
Now, if this were the case, the incidence of PE should be higher in dizygotic compared to monozygotic twin pregnancies, and similar in monozygotic twin and a singleton pregnancy. I hope you all agree with that sentence. If we say that is the cause, then after all monozygotic twin gestation is only one egg. So, whether it is singleton or monozygotic, the incidence should have been the same. Now, since 1/3 of monozygotic twins are dichorionic and about 10% of dichorionic twins are monozygotic, here the confusion starts. It could be anticipated that the incidence of PE would be higher in dichorionic compared to monochorionic twin pregnancies. Now, this study by Sparks et al., this has been published in 2013, demonstrated that the incidence of PE is similar in both types of twins and consequently is not supportive of the above concept, and it could be hypothesized that the higher immunological load as the increased placental mass in twin compared to single pregnancy implies that there is rather than greater feto-maternal antigenic differences which contributes to the increased incidence. So, we have two different factors, the feto-maternal genetic difference, and we also have the increased placental mass with a higher immunological load. So, it is believed that it is not the genetic cause that causes dysfunction. So, whether it is monozygotic or dizygotic thing shouldn't be different, but it is the immunological load. Okay, most of the studies say the same thing, and this particular study talks about the hidden high rates of preeclampsia in a twin. They call it as hidden because what happens is in a twin gestation generally they are delivered by anywhere from 34 to 37 weeks. Now, what they did was they tried to study how it would look if the twins were to progress till 40 weeks like a singleton, and it was definitely found that if we were going to continue twins till 40 weeks of gestation or maybe even till 41 weeks of gestation, the incidence of preeclampsia would be much higher. So, that is why this article called it as the hidden rate of preeclampsia. Now, this is a very interesting question for maternal-fetal medicine specialists. Does the death of one fetus lead to amelioration of PE? Supposing the patient has got preeclampsia with twins and dizygotic maybe, and if one of the twin is reduced, would preeclampsia improve or no?
No, sir, it wouldn't improve because it's a basic pathology which is existent. How would the death of one fetus reverse the vascular insufficiency?
Now, there are cases reported in the literature
There are case reports
where after a spontaneous intrauterine death of one twin,
preeclampsia has
there has been an amelioration of the preeclampsia. Now, they hypothesized that the genetic susceptibility to preeclampsia could be confirmed by homozygosity for the same single recessive gene expressed by both mother and the fetus. So, if the same gene is expressed both by the mother and the fetus, then the possibility of preeclampsia is higher. Now, supposing that particular twin dies and the other one is surviving, then the preeclampsia disappears from this twin gestation. Very, very confusing and very, very, I would say, kind of a philosophical thing. But you can see there what happens. And people, what did they start to do? They said, okay, if one spontaneous death decreases preeclampsia, supposing I have a preeclampsia at 24 weeks of gestation, if I reduce one twin, what would be the chance of getting a live baby at least near term instead of delivering at 24 or 26 weeks? They did a study and they found that a selective termination resulted in a better outcome. Now, these are all just initial studies coming in. A lot more work needs to be done, but these are food for thought. Now, the next important aspect would be the decreased fetal growth. We all know how placental restriction can result in a decreased growth. So, Dr. Revati, or you want Dr. Srividya, okay, what about IUGR with twins? What are the types of IUGRs you can get with twins? Or I don't know if Dr. Shrija would like to answer. What are the various types of IUGR you can get with twins?
Okay, now we have two scenarios where both babies can be affected.
Absolutely.
When it could actually point towards a global problem, especially in the mother, or it can affect one of the twin. Now, if it is one of the twin, it could be either in the monochorionic placentation or it could be in the dichorionic, in which the outcomes are bit different and the age delivery also differs.
Could you blow up the slide, please? There's too much material, so unless they see the full slide, it will not be seen. All right. So this was a case control study of 313 patients with twin pregnancies. This has been published in 2011, and they used three definitions for IUGR. Either twin with a birth weight less than 10 centile for gestational age, that's the standard definition. Either twin with a birth rate of less than 5th centile for the gestational age, and the third definition they used was a birth weight discordance greater than 20%. And using each definition of this IUGR, they estimated the association between IUGR and maternal age, weight, monochorionicity, in vitro fertilization, pregnancy reduction, thrombophilia, hypertension and diabetes. All the factors were compared, and they say that, however, in twin pregnancies, IUGR cannot be predicted by maternal risk factors. So it's easy to predict IUGR in a singleton, but not in a twin. And how do you manage once you pick up the IUGR?
In a DCDA twin, if there is an IUGR, it is equivalent that we follow up the case as good as in a singleton pregnancy. We do see the baby once in 2 to 3 weeks based on the Doppler findings and the growth discordance. And in case of a monochorionic pregnancy, we do follow up every 2 weeks irrespective whether there is growth discordance or not. So that's a protocol where for MCDA. If a growth discrepancy is there, again the follow-up will depend on the Doppler changes. If the Doppler changes have started, then it has to be weekly monitoring.
All right. Now, we have the ART centers sometimes putting in 4 embryos, 5 embryos. So you get triplets, quadruplets and so on. Then they go in for a multifetal reduction. Now, if a patient undergoes multifetal reduction, can it cause FGR? That means we have to counsel the patient before she goes in for a multifetal reduction. That all right, your 4 fetuses will now become twins, but you can land up with an FGR. Is that what we need to counsel? Okay. Now, multifetal pregnancy reduction does not reduce the incidence of IUGR in the remaining fetuses to that of non-reduced twins.
Unlike preeclampsia.
Absolutely. So there is no effect of it on these complications. Now, what could be the possible causes for discordancy in a twin? One baby is big, growing normally, the other baby is small. What are all the possible causes?
If it is a DCDA twin, it could be that one is properly perfused, the placenta, and the other is less, it's more compromised. That could be, and this could be because of all the background risk factors which already exist. It's very difficult to actually find out why is one twin, less perfused. And there have been incidences where DCDA twin have had sharing anastomosis. So that is something that is not actually picked up. So that we have to be probably monitoring on a working diagnosis. But if it's MCDA, it's already established that there is this, the twin-to-twin transfusion which commonly occurs, which could lead to discordant growth.
Anything you'd like to add?
Once we see there is a growth discrepancy, first thing is like we have to see whether structurally the fetus appears normal for that gestational age. We have not missed out because majority of time growth restriction can be associated with chromosomal problems or genetic factors and also the abnormality, structural abnormality. So once we rule out all these things only, we can come to a conclusion of a isolated fetal growth restriction seen.
Absolutely. So the discordant twins could be due to 3 different reasons. One is the differences in genetic potential between the twins. Number 2, a placental dysfunction confined to one placenta only and one placental territory with a shared placenta. In addition, even when you have a twin-to-twin transfusion, which is a distinct separate entity altogether, we are not going into it. Now, what is important is once there is a discordant growth, the risk of adverse perinatal outcome increases. And whether the sonographic parameters, which sonographic parameters are more predictive of discordance, we are still not sure. But what is needed is a heightening of a fetal surveillance, follows the principles applied to a singleton pregnancy complicated by growth restriction. The timing of intervention depends on chorionicity. Okay, now another very important, interesting article which I found, this was in 2011, was that whenever there is a type of cord insertion, the type of cord insertion in a diamniotic monochorionic twin placenta and the distribution of twin territories plays a very important role. And more confusion now. We already heard a little bit about miRNA in the morning as a treatment. Now, the microRNA profiles of placenta complicated with selective intrauterine growth restrictions are unknown. However, single IUGR occurs in 10 to 15% of monochorionic twins and is associated with an increased IUFD and neurological adverse outcome in both twins. Now, what this article from 2017 found was that key mRNAs and pathways which transform growth factor beta, mitogen activated protein kinase and WNT are identified to be associated with pathogenesis of SIUGR. So, morning we heard how miRNA could be used, could be manipulated to prevent preeclampsia. Similarly, miRNA could be manipulated to prevent a single discordant IUGR. So, these are the things for future. This article has just come in 2017, maybe by 2027 we may have more details about it. Now, is SIUGR, that is single IUGR, associated with PE? If there is only a single IUGR as compared to double IUGR.
You mean in a twin pregnancy, if there is one fetus?
One single IUGR, SIUGR.
Yeah, it could be because of preferential perfusion of one placenta.
Absolutely, or a preferential ischemia of one placenta, the incidence of PE could be more. Okay. Now, this is just to complete what do we mean by SIUGR or a selective intrauterine growth restriction. It occurs, intrauterine growth restriction occurs in 3 to 10% of singleton pregnancies, 9% of twin pregnancies and 9.9% of monochorionic twin pregnancies. Up to 32 weeks gestation, the growth rate for twins should be the same as for singletons, but after 32 weeks, the growth in the twins slows down due to the restricted space in the womb, uterus and placental insufficiency. Okay, in triplets, this process starts earlier. The degree of difference between the twin or the multiple babies can indicate the degree of IUGR. Mild, 15% difference, moderate, 15 to 30% difference, and severe is more than 30% difference. Okay, is there a difference in placental dysfunction between spontaneous and IVF twins? That means when an IVF twin comes to me as compared to a spontaneous twin pregnancy, do I have to behave differently?
Absolutely, because there is more placental dysfunction in IVF conceptions.
Okay, so this is the way the distribution occurs between all twins, spontaneous and IVF. They have even tried to differentiate between monochorionic and dichorionic spontaneous gestation versus IVF gestation. What was important was that when there was a monochorionic spontaneous twin, the incidence of TTTS was only 12.7%, whereas if it was an IVF twin, the TTTS went down to 2.3%. Now, the figures are small, but whether this is really true or not, we are still not sure. All it tells us is that TTTS could be more in spontaneous twins as compared to IVF twins. Okay, now we go over to the next type of a scenario with twins. Now, this is the story of a 33-year-old primi gravida with 20 plus 6 weeks of gestation with DCDA twin pregnancy, early onset of severe preeclampsia, severe proteinuria, SLE with class 2 lupus nephritis. Okay, now there is everything anti-DS DNA is highly positive. Patient has come with early onset preeclampsia, and because we were not sure of the diagnosis, we went ahead and did a renal biopsy which proved that there was an SLE class 3 glomerulosis. and she went on worsening, and ultimately she had the mid-trimester expulsions of the both the fetuses. We lost that pregnancy. Now, what about medical disorders predating gestation that are associated with placental dysfunction? We all know that elderly twins are more common. Now, once their age increases, the chances of other medical disorders coming in are also more common. Is a normal twin, so-called normal twin, without any risk factors, without any medical problems, and you have a twins with medical problems, what would be the difference? Is the association of placental dysfunction more?
Yes, with medical problems more, because there's already pre-existing endothelial damage with a stress. So that stress worsens oxidative damage. So all the probable changes would occur much earlier and it would be of greater severity.
Absolutely. So CKD, even in its early stages, if there is a twin pregnancy associated with higher risk. Okay. Now the relationship between kidney and placenta is being clarified in typical preeclampsia, in which placental ischemia leads to widespread activation, dysfunction of mitral vascular endothelium, oxidative stress, and an imbalance between pro-angiogenic and anti-angiogenic factors. We know that. Now, presence of even mild renal damage may lower the threshold needed for evident endothelial kidney damage in pregnancy, and conversely, the factors of renal origin, thus far unknown, may affect the placental circulation, particularly in the later stages of pregnancy. The larger placenta of multiple pregnancy could enhance these pathological responses. So these are the theories that are right now making round. Now next we come to another situation where you have a twin with a normal baby and a molar pregnancy. So one twin mole, one baby normal. Okay, so this is the patient with the normal placenta and the mole, the histopathology proving the mole, and that's the normal baby at delivery. What kind of placental dysfunction would you expect?
Fetal growth restriction.
Preeclampsia. As it is in a molar pregnancy, preeclampsia risk is high. So it gets worsened with a twin pregnancy. Associated implications of preeclampsia, which is fetal growth restriction and things like that, gets worsened. Abruption.
Absolutely. So when you have one twin and one mole, 45% only will progress up to 28 weeks. That means 55% of the pregnancies are going to be lost before they touch 28 weeks, and about 70% of this 45% will survive. A normal placenta supplies nutrition to one twin. The co-pregnancy is a complete molar. Optimal management is uncertain because we have very few cases reported in the literature, but preterm delivery is frequently required because of bleeding, or as Dr. Revati said, severe preeclampsia. Now this is another, we go to now higher order multiples. This would hopefully be the last case. This is a 32-year-old lady married for 10 years with previous 2 abortions, came at 18 plus 6 weeks with IVF, FET conception, triplets, reduced to twins at 16 weeks with antepartum hemorrhage, premature contractions. She also was GDM on insulin, anemia, thrombocytopenia. You know, problems never come single, they always come in multiples. And with possibly with DIC, and ultimately found to have a placenta increta and a massive PPH. When she came to me, the uterus was already irritable, lot of bleeding PV. This was a very precious pregnancy, tried to save it, but it did not work. Bleeding went on increasing. There was a cervical cerclage which had to be removed. And these are the 3 babies, the twin A and twin B, and twin C is the reduced twin. They all came out. There was a massive PPH. You can see the amount of blood loss that was there at the time of expulsion. And we had to take her up for a uterine artery embolization. Totally she received 13 transfusions, 7 PRBCs, 4 FFP, 4 RDPs. Further course was uneventful. The placenta was partially adherent, so I had given a methotrexate also, and beta HCG by 13 they reduced to 19 international units, and patient was discharged in a stable condition on day 17, but after a lot of heartburn. So what about the higher orders? What would you like to do for them? The higher orders. We are not talking of twins now, triplets, quadruplets.
Okay. Majority of the time, triplets or quadruplets, when we explain the risk factors to the parents, they go in for a reduction. So it's a very rare condition that we follow up with the twins or a triplets to go or quadruplets to continue beyond 13 weeks. And we expect all the complications to be doubled than the twins, what is expected. So let it be a preeclampsia or a fetal growth restriction. So all the complications increases with it.
So most of the studies do say that. I mean, when you actually reduce a higher order gestation to twins, it's always, it normalizes to that as a spontaneous twin. But then it's again left to the discretion of the patient. There are patients who want to continue multiple, I mean, we've not seen people continuing quadruplets. Most of them want to continue triplets. That's when the risk increases.
What kind of risk, what kind of placenta
Preeclampsia.
dysfunction are you talking? What kind of preeclampsia?
Early onset, severe preeclampsia.
Early onset severe preeclampsia with HELP syndrome is very, very common in this higher order pregnancies.
With quick progression.
So thank you. Now this is not a twin baby, this is only a single baby actually, and that happens to be my granddaughter whom I delivered 2 months back. Thank you very much.
Thank you.
Thank you, sir. Thanks. We need to get back after the lunch break exactly at 2 because we have to catch up with Spain. We have Dr. Oyer Ratika, who's worked in the lupus clinic talking about seronegative APLA. Then we have the biomarker workshop. So we're going to be discussing case scenarios and how we actually interpret biomarkers. So we expect all of you all to be in the hall at 2 o'clock.
That's why we were quick, so that we could come back and catch up with Spain. The prizes we leave it on. Just 1 minute. And here is the list of winners. Where are the prizes? Okay, you can start giving them the certificates till they decide the result. All those who have presented a poster, please come over. Okay. We have only 2 prizes. So no tie up, please. We have only 2 prizes. Okay, the first prize goes to Bartter syndrome, Dr. Manjula. That's the first prize. The second prize goes to pregnancy with livedoid vasculopathy, Dr. Sheetal. We had 3 other posters: successful delivery of CML baby, Dr. Atika; maple syrup urine disease, Dr. Grazia. Please collect your certificate. And successful pregnancy outcome in a woman with anti-Ro-La antibody after previous affected fetus, Dr. Priyanka. Please collect your certificate. Please give them a big hand. All these youngsters have put in a lot of efforts. It's not easy to make a poster. And we don't give them time, first of all. So somehow they have found time and done the work. Priyanka. Everybody, I hope everyone has had a nice lunch. Okay, now we have one person here with us who was actually like a catalyst who brought about the formation of the Society for Maternal Fetal Medicine. Without her, probably or without her goading and pushing, I don't think we would have really gone ahead and tried to do these kind of things, because each of us are busy in our own worlds. And we would have just left it at that, but then she said, no, you have to do it. And that person is none other than Dr. Kamini Rao. So I now request Dr. Kamini to say a few words, and then Dr. Revati, please hand over a memento.
So thank you, Prakash and Revati. A very dear colleague of mine, and another student come now, a junior colleague of mine. I think it's important for me to see a conference like this, because it's not the numbers that matter. It is the quality of the program that you do. In fact, when you talked about Sarosh Rana, and then you talked about APLA, in fact, that immunomodulation of pregnancy actually started with us in Kumara Park. And so many of those pre-eclamptics, we were able to take them and get the live births in these cases. And I think this is what is important. And today what I see is that youngsters like yourselves have to take this forward, and you have to get in more people involved, but less of politics and more of academics. And this is what I dream of when I say fetal-maternal medicine or maternal-fetal medicine. Because if you look at fetal-maternal medicine, that's a passion for me, because I did my master's in that. But my profession is IVF, or assisted reproduction. So the passion is still what you have here. But I've grown in years, and obviously your brain is not as active as it used to be maybe a decade ago. So I would certainly leave it to the experts like Revati and the entire team here, and to take this forward. And I'm very happy to say that this is really going great guns, because it's an effort from all of you, to be able to get all these programs coordinated, with the audiovisuals and the speakers as well. But what I've heard from the speakers like Sarosh Rana and the others, they have great regard for this particular program, and also for Revati. So what could be a better kind of gift that I can get from outside speakers, when one of our students only are being appreciated to that extent? I think that is the best gift that I can get. And keep it up, Revati. You've done a great job. And Dr. Prakash as well, always a backbone. I remember when we did the AICOG conference, he used to be up early, and he used to come, and we used to sit on. Almost no day passed when he had not come to the AICOG center. And I think, those were some of the most pleasant memories that I've had. Jyotika was there, all of them. And, we really loved the program. And when the program got over, we felt a kind of a void in us, that we should be meeting more and more. So I think that is what this maternal fetal medicine society should be. Smaller groups, focus programs, please keep on meeting. And this annual program as well. All my best wishes to you people for a very successful, not only program, but also future programs. Thank you very much.
Intro? Somebody introduce?
Good afternoon, everybody. We reassemble again for the afternoon sessions. The first is something that is always quizzing the obstetrician and the maternal-fetal medicine specialist. Is it APLA or not? Do we have something called seronegative APLA? Here it is. We have a session from Dr. Oer Atika Barusia. He's an obstetric medicine specialist from Spain with special interest in clinical immunology and thrombophilia. He's an active member of the Global Obstetric Medicine Initiative, and that's how he's associated with us, because he is actively involved in the spread of obstetric medicine globally through the International Society of Obstetric Medicine. He's worked in the Lupus Clinic UK, And now he's also authored several scientific papers on APLA, and his special interest is seronegative APLA. Over to Ober.
Dr. Oyer is actually traveling, so his lecture is a recorded one, but he will be available. He'll reach Spain in a short while, and from Spain we are going to have a direct interaction with him.
Hello, good afternoon, everybody in Bengaluru. This is Oyer Arteca from Bilbao in the Basque Country in Spain. I'd like to thank you for your kind invitation to be part of this interesting first meeting of the Society of Maternal Medicine in India. I hope I can, in the next few minutes, I can summarize some of the important aspects of the antiphospholipid syndrome in pregnancy, and mainly the quite trendy seronegative APS and mainly the management of that in pregnancy. As you all know, let me just check with as you all know, the obstetric part of the APS was from the very beginning in the definitions and the cases that were presented early, well, in the 80s probably. There was a very important paper that was published by Professor Hughes in 1983, which has been marked as the first description of the syndrome. As you all know, in that paper, the obstetric recurrent pregnancy loss was defined as probably one of the features of the syndrome. And as you know, and you see, not just that, but also the thrombosis and thrombocytopenia and livedo reticularis, which, as you will see in the next few slides, it is quite important for us in the seronegative APS and even in the diagnosis of all the antiphospholipid syndrome. Antiphospholipid antibodies are found more frequently in patients with SLE rather than in any other autoimmune rheumatic diseases, and depending on the cases and series, it has been said that in general population probably is 1 to 5%. We know that the APL represents one of the major risk factors for poor obstetric outcomes, and in the well, quite several studies since those 80s till now, the APL have been related to pregnancy loss, preeclampsia, NIUGR, prematurity, and thrombosis, of course. One of the biggest studies, prospective studies in APS, is the Euro APS, with more than 1,000 patients that the Ricard server in Barcelona has been leading. We know that other than the obstetric manifestations and deep vein thrombosis, there are other clinical manifestations important, as I was saying, to the syndrome, like thrombocytopenia, livedo reticularis, epilepsy, skin ulcers, and valve involvement, and also the autoimmune hemolytic anemia. As you see in the obstetric manifestations, it's quite interesting to see that from the diagnosis till the end, the early pregnancy loss and the late pregnancy loss is a problem that even with treatment is difficult to control. In that regard, taking into account all these different clinical manifestations, there was a first Sapporo criteria that were updated for the Sydney criteria that nowadays we have. I'm not going to go through all the details of them, but as you know, we need one clinical criteria and one laboratory criteria to say that a patient has got or to classify as a definitive APS. And probably if we don't have a lab criteria or a very clear clinical criteria is when we can say it is possible or probable for the patient to have it or not. As you know, the prevalence is not clear, neither the incidence of APL in the general population and neither the APS, but what we know is that the estimation, more or less, it has been said that the prevalence could be between 40 and 50 cases per 100,000 persons in the general population, and the annual incidence would be 5 new cases per 100,000 people. The APS action group did a quite extensive review, and lately they published that in the general population, if we take these features of pregnancy morbidity, could be up to 6% that the APL are involved. 13% of patients with a stroke may have the APL, and the same for 11% in myocardial infarction, and up to 9% in general population of deep vein thrombosis. The mechanisms through which the APL exert their effect is not still well known, but what we do know is that these antibodies have got an effect activating the complement, and also with a pro-inflammatory state, oxidative stress, endothelial injury, and activation of the several cells that are involved in this syndrome, and all these changes take us to thrombosis and pregnancy morbidity, amongst others. And this is why new pathways that have been described are bringing new ideas and new methods for treatment. I would like to highlight the hydroxychloroquine, statins, and other antiplatelet drugs as new lines for treatment that have lately probably brought new insights to the treatment of the syndrome. With regards to the obstetric APS, we know that these antibodies have got effects in abnormal placentation, both decreasing the angiogenesis, the invasiveness of trophoblasts, but also we've seen that the thrombosis that we saw in patients with general APS can be seen in the placenta through that way, and also the inflammation path with the complement activation, and also the activation of neutrophils, macrophages, and other pro-inflammatory paths like the TLR4, etc. This is just the same. What we do know of studies in placenta is that pathological changes are not always present in APS, and so there is no very good correlation between what we see in the placenta and the outcome of pregnancy, although it is obvious that when we do have a very small and pathologic placenta, it's difficult for a normal pregnancy to develop. If we look at the recurrent miscarriage guidelines in general population, we see that amongst all the reasons and causes that we have to check, and when we do have a woman with recurrent miscarriages, one of them is APL. But do we really know how important that is? Well, it is true that if we see a woman that has got 2 or 3 miscarriages, and one of the first things that we will want to do is to check the antiphospholipid antibodies. But if we look at recent papers, what we see is that it's not that common to see that those women are positive. And actually these 2 recent papers show that. So in this first one, so amongst 108 women, only 4 had APL positive, and and this study that was published in 2015, amongst 338 patients, only 5.6% were tested positive, at least for one APL, which is not much. If we look at the stillbirth general population, it happens more or less the same. Even if we see that there are quite a few women that have got IUGL, preeclampsia, and that kind of problems. If we look at this series of Silver et al., we see that 582 patients with stillbirths were checked, and only 7 of them had APS as a probable cause of death. In a more recent paper of the same Silver and colleagues, in this case Page is the first author, they are a bit more concrete, and they say that probably in 11% of all those 512 patients, stillbirths, it was pertinent to check antiphospholipid antibodies, either for a pertinent negative result or a positive, which is not that much. What we do know is that antiphospholipid antibodies are not the same, either to have only one of them positive and which of them. So we do know that the risk is higher when lupus anticoagulant is positive, when the titers of anti-cardiolepin antibodies are very high, when both are together, when we do have APL together with lupus, and obviously the triple positivity of the APL. But amongst all of them, the thrombotic APS women are the ones that will have the highest pregnancy risk. Despite that, both in the 13th International Congress of Antiphospholipid Antibodies and in the 14th, so in the latest two ones, what the task force expert conclude is that except for the fetal death, there are limitations in the quality of data supporting the association between APL and obstetric complications, and the treatments for all pregnancy morbidity in APS also lack well-designed studies. So even if we've seen in the observational studies and case controls that there is an association, it's not that good quality data. So what is this idea of seronegative APS? Well, anybody, as we were saying in the beginning, we do know that might be, or it is, to have a clinical APS, or either a thrombosis or obstetric pregnancy morbidity that come in the Sydney criteria, but without a positive antiphospholipid antibody present. So the first time that this seronegative antiphospholipid syndrome was mentioned as such in the literature was this paper by the same Graham Hughes, so Professor Hughes and Professor Kamashta in the lupus clinic at St. Thomas's in London. That in the last paragraph they were saying the history of seronegative rheumatoid and lupus has provided useful lessons and suggests a positive approach towards seronegative APS, meaning that what happens with lupus and RA, that we had quite a few patients that were negative for the tests that were checked in the past. Nowadays we've got more sensitive and specific tests that have either confirmed the diagnosis of SLE and RA in some patients, and in others they've ruled out them. So they were mentioning that probably in these patients that we see in our clinics with quite suggestive clinical manifestations of the APS, but with negative antibodies, probably what's going on is that we don't have the most powerful tools to diagnose them with regards to the laboratory criteria. Sorry. The possibilities of this seronegative APS, I think that are three. One is that we've got a laboratory error, so even the patient is positive, the method that we've used or in the lab, so there has been an error, so you can have a negative test, but truly be positive. We also have this is more rare, but still possible, the consumption of the antibodies, sometimes with infections, with severe proteinuria, or when patients are in immunosuppressants or have got acute thrombosis. Sometimes there can be a quite significant decrease of the antibodies, and that's why in the laboratory criteria of Sydney we do have the need to repeat the test 12 weeks apart. But the main seronegative APS is when it is real, when repeatedly we do have a patient that is negative, and the possibility of this is probably that there are other antibodies that should be tested and may be positive. And we will go through them later, but as you see, we talk about the IgA antibody of current ones or other antigens, and that we will talk later. Diagnosis of seronegative APS, however, may increase the ratio of false positives, and we do need to have that in mind, mainly in obstetrics, because that may lead to unnecessary treatments and management, and obviously higher emotional and economic resources consumption. What we do know is that when we test antibodies for other either phospholipids or phospholipid binding plasma proteins, phospholipid protein complexes, etc., the yield of the diagnosis increases, and this is what quite a few people in the last probably 20 years have been working on. This is one of the lists that I think it's quite useful to see that, because yes, we do have quite a lot of antibodies, but not all of them are as present as others. And yes, we know that, for instance, anticardiolipin and beta-2, like protein 1, are quite frequent in antiphospholipid syndrome. But what we do also know is that nowadays there are other antibodies that may be very interesting for the diagnosis, and we'll talk about these. Mainly, I would mention the anti-APSP2, so the phosphatidylserine prothrombin, and the anticardiolipin bimentin. The phosphatidylethanolamine probably is not as interesting, but we'll talk about that in a minute. I would like to bring one of the studies that I was firstly involved in when I was working in London. This is a cohort that we recruited 54 patients, 87 were seropositive APS and 67 were seronegative. How did we define the seronegative APS? Well, what we did is to take patients that had major clinical criteria for APS and at least two of the following non-criteria, so clinical manifestations that are not in the criteria but are associated to APS, as I was saying before. So liver urticularis, Raynaud's, migraines, headaches, that use has always been very dwelling on this. Cognitive dysfunction, seizures, chorea, multiple sclerosis-like illness, brain MRI, white matter lesions, mitral and aortic valve disease, one or two spontaneous abortions, and thrombocytopenia. And what we saw when we recruited these two groups of patients was that both in the seronegative and seropositive APS groups, the clinical criteria were very alike. And that was quite reassuring in terms of having a quite homogeneous population. So even if they didn't have, the seronegative ones didn't have the laboratory criteria, clinically were quite similar to the seropositive. So after that, what we did is to test these patients for another 11 non-criteria APLs, and these are the 11 non-criteria antibodies, the IgAs for both cardiolipin and beta-2 glycoprotein 1, domain 1 IgG, and then the anti-phosphatidylserine, anti-phosphatidylserine prothrombin, anti-phosphatidylethanolamin, and, as I said, anti-cardiolipin vimentin. As you see, in the seronegative group, there were quite a few positives, and what we saw is that more than a third of the group of the seronegative APS were positive for at least one, and more or less 83% of the seropositive ones were positive for one of them. So these were quite interesting data that we've been focusing lately. We also wanted to check from all these antibodies, so APSPT, APT, AP, etc., which were the most interesting, more powerful to diagnose antiphospholipid syndrome. And what we did is, in a cohort of lupus, we checked for different combinations, and what we saw is that apart from lupus anticoagulant and beta-2 glycoprotein 1, when you added the APSPT, so phosphatidylserine prothrombin, you got the most powerful combination. So quite interesting data to bear in mind. And as I said, I think that I won't go through all the details, but in the last task force that was held in Rio in 2013, the task force clearly was talking about these two antibodies like the possible ones for in the future, also the domain 1 of the beta-2 glycoprotein 1, for in the future be useful and may be included in the classification criteria. The scenarios that I was thinking that can be possible for us to see in the clinic for seronegative APS are patients with the clinical manifestations with negative or non-criteria APL. So if you don't have any other test other than ACL and lupus anticoagulant, but they are not very strongly positive, or they come and go, or so they are borderline. Sometimes you will think, is this antiphospholipid syndrome or is not? So I thought that there were two scenarios. One is when the thrombosis is present, either with SLE, with previous bad obstetric outcomes, or with non-criteria clinical manifestations, and the block that has got poor obstetric outcomes and either SLE or non-criteria clinical manifestations. So I will try to answer some of the questions that you may have regarding what do we do with these patients. So before we talk about the management of these patients, I think we have to keep in mind and clearly what the treatment is for currently for the antiphospholipid syndrome patients in pregnancy. Obviously, I would highlight the high-risk pregnancy monitoring and management clinics with high-risk management with multidisciplinary care and combined clinic, baseline assessment and monitoring throughout the pregnancy, screening for preeclampsia in all the patients early in pregnancy, serial ultrasound scans, and depending on the outcome, timely delivery. I won't go through this because I assume that probably most of you are obstetricians, so uterine artery Dopplers and mid-trimester pulsatility index are probably tools that you use in your daily basis. I think that it's interesting what happened probably after 2006, 7, when the groups in London and many other groups in the world started with the parametric test for early onset preeclampsia, mainly checking women early in pregnancy, either with ultrasound and some markers. But what I would like to highlight is that nowadays we know that early uterine artery mean pulsatility index and the angiogenic factors ratios are good predictors of adverse pregnancy outcomes in the general population, obviously, but also in APS and SLE, and more importantly, they are independent for SLE flare or activity, which is something that until now in the clinical practice wasn't that easy to differentiate. So as I was saying, the main ideas of the management of APL positive women, the current recommendations of the task force of APS is that in a woman that is just a carrier, we could either do nothing or treat them with low-dose aspirin. I think that this paper, the paper that was published by the group of Catherine Nelson Pierce in London, where they treated patients with APL, APS and controls, so they followed them up in pregnancy. So APL and APS patients, they were treated with aspirin, and what they saw is that the carriers did as well as controls while taking aspirin in pregnancy. So I think that this is enough, it's a very suggestive data to say that nowadays what we should do with the carriers in pregnancy, as aspirin, low-dose aspirin is quite beneficial and harmless, we could treat them with the low-dose aspirin. In terms of recurrent early miscarriages, in the past it wasn't very clear whether we should do either only aspirin or heparin and aspirin. I think nowadays we do have enough evidence to support the second one. And actually, although the recommendations are those, I would bring some of the latest papers that I think are interesting. This one in China, for instance, they followed up more than 1,000 women with recurrent pregnancy loss and APS, and what they saw is that the ones that were benefiting from aspirin and heparin were those that had high elevated D-dimer early in pregnancy and during pregnancy, which is something that I wasn't aware till that anybody has described, but there's a high number of patients, and I think probably in the future we should bear in mind. Conversely, we do have this Cochrane review that says that in recurrent unexplained miscarriages, there's no beneficial treatment, or at least in randomized controlled trials, which is just against what we were saying. And this one also, Jane, is, I think, so 49 randomized controlled trials with more than 8,000 patients, and the conclusion was that in consideration of live birth and abortion rates, in general population, corticosteroids plus aspirin plus heparin was the best treatment. And in the subgroup analysis of anti-phospholipid syndrome, there wasn't benefit from the current treatment. So a lot of uncertainty, as you see, but I think that we should keep in mind what the task force says. The heparin and the action of heparin immune response is very well described, and there are quite a good beneficial effects. But there is one of them that upregulates the soluble FMS like tyrosine kinase and all this. So what may happen is that there are some effects of the heparin that may go against the benefit that we want to get from the heparin, mainly in preeclampsia and IUGR. So what do we do with these late fetal loss, severe preeclampsia and IUGR? Well, we don't have much of evidence behind that, but still it looks like this is the treatment, so both aspirin and heparin. And if we do have a previous thrombosis patient with APL, we do know that we should keep low dose aspirin and the heparin at least high prophylactic dose or anticoagulant dose. The latest data suggests that all these women with appropriate management will have a 70 to 80% of success in pregnancy, which is very important. And what do we do with refractory obstetric APS? Well, there are quite a few papers, mainly in the last 10 years, that say that prednisone low dose, so prednisone 10 to 15 milligrams, or hydroxychloroquine, or even IVIG and plasma exchange can increase the outcome of pregnancy. I don't want to forget the importance of the APL in these women. And as you see, there are two studies that I want to bring. This is a study, the survival in the follow-up. So when women are followed up after having had a recurrent miscarriage, and what they see is that women with APL have got a higher incidence of thrombosis in the future. So even if they look like they are not as APS as the probably IUGR or bad stillbirth or preeclampsia patients, they have a higher increase of thrombosis in the future, and the same was described in this paper. So I think that in general, postpartum, we should have in mind the thromboprophylaxis for all these patients, either if they are only carriers just for 7 days of heparin, or for longer, depending on the features of the thrombosis. Also, for all the women, they should be assessed for VTE early in pregnancy, and I'm just mentioning these guidelines that the RCOG has got available that are very interesting. So, what do we do with these patients that have got these late preeclampsia, IUGR, severe preeclampsia, late fetal loss, and IUGR? So I think that we should keep in mind other things that are important in treatment. One is that we should check all women for all the risk factors of hypertension. I'm not going to go through that. Two, I think that it's not the same to start aspirin either early or later in pregnancy, and we do have these meta-analyses that have proved that, published by the group of Kypros Nicolaides, these two meta-analyses that prove that if we start aspirin before the 16th week of pregnancy, the benefit of it is there, but if we start it after that, we may not get any benefit from it. There is another very interesting feature of aspirin, and is that there are, in general population, previous clinical trials that have suggested that the effect of aspirin is not the same depending on when we take the aspirin. And I would bring your attention to this paper that was published by a Spanish group, a very well-designed study in pregnancy. So what they did is they took this 350 high-risk women, and they did a case control trial with aspirin and placebo, and what they did is prospectively check them their blood pressure throughout pregnancy at booking and monthly until 32 weeks, and then every 2 weeks from 32 weeks on. And there were 3 groups in the aspirin group. It was either you take it in the morning, either more or less in the afternoon, or at bedtime. The results are striking. The ones that took the aspirin in the morning, they didn't get much effect in the difference of blood pressure measurements between the placebo group and the aspirin group. But when we see the blood pressure in these high-risk women, what we see is that the ones that took placebo didn't get much effect, and they had a high blood pressure throughout the pregnancy. But the ones that took aspirin in the afternoon had much normal graph of blood pressure in pregnancy. And even more, the ones that took the aspirin in the evening were the ones that got the best benefit from systolic and diastolic blood pressure. So when we looked at not only the blood pressure but the outcomes, all the outcomes were improved by taking the aspirin either in the evening, or afternoon, evening, or bedtime, which is, I think, very interesting. I will just mention also the importance of the calcium supplementation, mainly in those with poor calcium intake throughout a pregnancy and in life in general. So very big Cochrane review that has been published in the last years by Hofmeyr, and also not as powerful but also very important supplements of vitamin D, control of weight to prevent preeclampsia and bad outcomes. And lastly, I would like to mention the pravastatin that was firstly seen in mice, how was preventing the angiogenic imbalance and the preventing preeclampsia in the rat models. There was a concern about the safety of statins, but in this review that included, I think it's 200 and almost around 200 patients, 250 patients, what they say is that none of them had an increased congenital malformation risk. And that's why there was started a study in the States in the pravastatin for prevention of preeclampsia in high-risk women. We still don't have the data published of the results of that study, but what we do have, and I think this is, although a small important paper, is this recent paper that was published in the Greek group of Eleftheria and Lefko, and we see 10 patients and 11 patients, 10 didn't get other treatments other than heparin and aspirin, but 11 took pravastatin when either the IUGR or the preeclampsia was diagnosed. And what we see is that the difference is amazing, and actually the differences in angiogenic factors were seen by the 10th day of taking 20 milligrams of pravastatin. The weight difference was also amazing. Time of delivery is striking. So I hope that in the future we see more data, because these data, not only for the general population, but for, as you see, the obstetric and obstetric women, is very, very interesting. So what do we do with all these women that have clinical manifestations but are negative for APL? Probably you will be in a center that doesn't do research and don't have anti-domain 1 beta-2 glycoprotein or anti-vimentin or phosphatidylserine prothrombin. So what do we do with these? So there was a recent published paper that I think is interesting to probably answer at least part of that question. And this is the study of this group in France, that what they took is that they analyzed 474 pregnancies in around 170 something patients, and what they took is that all these patients with a clinical antiphospholipid criteria, and they analyzed not only the normal antiphospholipid antibodies but also these other non-criteria antiphospholipid antibodies. And what they saw is that there was a group that was positive for the non-criteria antiphospholipid antibodies. There was a group that was positive for the normal, so the confirmed APS, and there was a group that wasn't neither positive for these extra ones nor for the criteria ones. And I'm not going to go through all the data because there's a bit of heterogeneity in the populations, but there's a very important message of this paper, and is that if you compare all these three groups, what we saw was that the patients that, regardless of the antiphospholipid antibodies, took either aspirin or not, took heparin or not, steroids or not, or hydroxychloroquine, there was a huge difference in the pregnancy outcome. And I think this is probably one of the things that we have to bear in mind. Because if we don't treat the patients and we stay in the doubt, does she have the syndrome or not, she probably will do not very well. And conversely, if she takes the treatment, even if we cannot prove that she has got the syndrome, she may do well, and probably as well or nearly as well as some of the normal or well-diagnosed APSs. So what do we do for all these women? Well, I think that all the recommendations are okay, and we should follow them, but we also should bear in mind the ones that I was mentioning about the aspirin for whom. So do the screening, when to start it as early as possible, keep the dose at least of 75, and when to be taken, if you can tell them to take them at night. Don't forget to ask about the calcium intake and the vitamin D supplements, weight control in those mainly that are with a high BMI, and be aware that pravastatin may be something that we should be using in the future with the most refractory cases. So in conclusion, regarding the seronegative APS, although non-criteria APL can increase the diagnostic yield for APS, their clinical relevance is still debatable and needs to be confirmed by interlaboratory efforts towards the standardization and addition to larger longitudinal studies. In the meantime, we should consider each case's features individually and treat accordingly. There should be a balance between those false positives and the real syndrome. So keep in mind all these clinical features that I was mentioning and the scenarios, and treat them accordingly. I know that when you are in front of a woman that has had 5 miscarriages or even 5 stillbirths or very bad preeclampsias, what you want them is to do well. And it's very difficult to say, well, you may or may not have the syndrome. Generally, what we try to do is give them all the chances possible. And in general, for the APS as well, in general, I think we still need well-designed prospective trials to make possible the characterization of probably defined different phenotypes of APSs, and tailor the treatments better. In the meantime, I won't go through all the recommendations as I've mentioned, but don't forget, please, that there are other causes, and we should keep in mind other causes for early and late bad outcomes, and also the antenatal and postnatal PTE assessment for all women, as well as regarding the preeclampsia and hypertension in pregnancy. Thank you very much for your attention. I will be glad to answer your questions in a minute.
Hi, Dr. Teka.
Prakash.
Yeah.
Dr. Oyer, this is Dr. Revati.
Yes.
Good afternoon. That's
Good
from
afternoon.
Bangalore.
Hi.
I don't know what, I think it's close to noon at Madrid, if I'm correct.
Yes.
Okay. So we heard through the entire session, and now first of all, thank you for making this wonderful effort, traveling and answering questions. I think it must have been really difficult for you. But it was a wonderful lecture. Now the questions, the first question that I'm going to put it across to you. We were debating, this whole symposium is about preeclampsia, thrombophilia and nutrition in pregnancy. And incidentally, we discussed a lot of early onset fetal growth restriction and severe preeclampsia in a primea gravida. Are we justified in starting heparin, immunomodulating her with HCQS and corticosteroids? Are we justified in looking at APLA? That's my first question. During
Sorry, could you repeat? I cannot hear
sure.
you properly.
Sure. If you had a woman who has had, she's a primea gravida, and she's had severe preeclampsia, early onset fetal growth restriction, maybe at around 23 weeks, are we justified in looking at the tests after modifying the possible risk factors like endocrine factors and others, like good supplementation of vitamin D and correction of all the others? After excluding those factors, are we justified in, first of all, doing the APLA? And if APLA comes negative, are we justified in starting heparin, HCQS and steroids so that we probably may take this pregnancy to salvageability, which is about, say, 26 to 28 weeks?
Yeah, well, that's a very good question, because what happens in clinic, as I was saying in the presentation, is that you're in front of the woman, and you can either say, well, we don't have an answer, and please try again, or if we think that besides the obstetric complication, there is something else that reminds us that this could be antiphospholipid syndrome, as I said, having thrombocytopenia or libido reticularis or any other signs outside pregnancy that tells us that this could be antiphospholipid syndrome, I would say that probably yes. But there was one paper on repeated pregnancy loss that I presented, that even in that systematic review, they were saying that in general population, the treatment that is the most effective could be giving everything. And of course, that's something that if you discuss with the woman and you tell her there is no evidence behind this, and we can do either wait or try everything, that could be something that you could obviously think of, yes.
So to summarize to the audience, you're trying to say that yes, I mean there is no evidence to prove that we need to do APLA in a pregnant lady. But if you have a primary gravida with severe preeclampsia and early onset fetal growth restriction, and she's struggling at 23 weeks, we're still justified in telling her there's no evidence. But if there is a valid indication for us to maybe salvage this pregnancy to take it to viability by doing maybe an APLA or even rescuing her with low molecular weight heparin, if we are confident that the other risk factors are modified. Is that what you're trying to say?
Yes, I think that it is justified to check the APLA, and if they are negative and you have other signs that remind to antiphospholipid syndrome, I think it is justified. And it would be also justified if you discuss with the woman what your approach is. I think that's also important.
That's well said, Dr. Oye. Do we have a question from Idapal, Kerala? We have other centers also taking part. This is Bangalore, which is actually in the south of Karnataka, south of India. And we also have other states. We have Kerala and we have Mumbai. That's from Maharashtra, west of India. Who we have different regions participating. So probably we'll ask questions from Idapal. Idapal, do you have a question on seronegative APLA? Dr. Shrija, do you have a question? I can ask him again.
No, ma'am, thanks.
Mumbai?
No, ma'am, nothing here.
So do you want to... We have Dr. Prakash Mehta here, who's the president of the Society for Maternal Fetal Medicine. I'll hand over the mic to him.
Now, once we say that there is a strong history, a bad obstetric history, and we do the APLA and comes out as negative, ultimately, how do we pinpoint it to say, okay, this could be a seronegative APLA? Because there are a lot of patients who clinically fit into the mold of APLA, but when you do the tests, everything comes back negative.
Shall I answer? Is that right?
Repeat the question.
Can I go ahead? Can I answer?
Can I answer?
Yes, please. Yes, please.
Yeah, so as I was saying before, we need, this is not just about having an obstetric complication or criteria. You need to have other criteria and other clinical signs to think of antiphospholipid syndrome, like thrombosis or like, as I was saying in the beginning of the presentation, thrombocytopenia, libido reticularis, skin ulcers, valvular thickening and dysfunction, etc. So I think that even you having only, if you have only the obstetric complications, it's very difficult to justify the diagnosis of antiphospholipid syndrome unless you have non-criteria APLA in your lab. So you should have other clinical signs to think of antiphospholipid syndrome, because there are many women that haven't got seronegative antiphospholipid syndrome and do have bad preeclampsia and IUTR.
Mm-hmm. Anybody else?
Do we do phosphatidylserine ಅವೆಲ್ಲ ಮಾಡಬೇಕಾ ಕೇಳಿ?
What would be the value of checking for phosphatidylserine or choline?
So, sorry, say again?
Phosphatidylserine or phosphatidylcholine, do we need to check them when everything else comes negative?
So
the other antibody.
Nowadays, there is no consensus what to do if the anticardiolipin, lupus anticoagulant, and beta-2 glycoprotein are negative. We are still waiting for the task force to decide whether there is any other test that can be added. So nowadays we don't have the next test to think of antiphospholipid syndrome when the rest are negative. As I presented, probably in the future the antiphosphatidylserine prothrombin will be one of them, but there is no consensus yet.
Thank you. Anyone else? Okay, there are a lot of contradictions about doing an APLA test during pregnancy. See, the patient has not come to me before pregnancy, she has come during pregnancy. I find that there is IUGR. I would like to do an APLA test, but there are a lot of people who say, no, you should not be doing it in pregnancy, it doesn't help much. What do you think about it?
In general, APL in pregnancy will, if anything, will be slightly decreased. And sometimes that is the thing. If the levels of mainly the antibodies are low or middle, you may think that this is not enough to say that it's antiphospholipid syndrome. So that may be the reason to say that you shouldn't check in pregnancy. But I think if the suspicion is high, you could test them and be aware that sometimes in pregnancy they can be slightly decreased, and therefore you will have to remove them for sure in the postpartum. But if you test a woman for the antibodies and they are low or middle positive, I think it's something that you have to bear in mind in order to think of the thromboprophylaxis in the postpartum period, which would be the most important thing for the woman. It's the only thing that I could think of for the antibodies to be useful and be checked in pregnancy, because once the IUGR is there, it's quite late to start the woman in aspirin and heparin, I guess.
Sure, thank you. Thank you very much.
We have to give him the mementos. Yeah. Dr. Oyer,
yes.
We are honoring you for your efforts, and Dr. Prakash Mehta is going to hand over a memento which is going to be FedEx to your address. So Prakash is going to WhatsApp the picture of the memento, and yeah, we've already WhatsApped the picture to you. This is an elephant from south of India. So this carries the SMFMI logo in memory of this event. And this is incidentally the first annual meet of the SMFMI, and we were launched 1 year ago by the ISOM. So there's been a long connection with the ISOM, which is continuing. So earlier today, we had Dr. Kenneth Chen also talking. So thanks a lot for everything, Dr. Oyer.
Yeah, thank you. Thank you. It's been a great pleasure. Thank you very much.
All right, Dr. Teka, we are signing off. Thank you very much.
Thank you. Thank you.
After session on the implications of the biomarkers, we saw a lot of studies on the biomarkers. So we'll probably take you from the Indian perspective. So we're going to have the workshop on the biomarkers. So the workshop is going to be broadly divided into introduction where we're going to give you an idea as to what and how we do the biomarkers and why. Then we have the next session where we have 5 case scenarios. We have rule-ins and rule-outs with the biomarkers. Then we have the studies, and also we're going to touch upon a little bit on the collaborative research work that we're doing with the Maternal Field Medicine Unit Chicago. And then finally, how do we do the test and the summary? This is the broad outline of the workshop. So this is essentially the Indian experience. We had Dr. Sarosh Rana talk about the global experience. For the introductory slides, we all know prediction is an essential prerequisite to prevention. So it's all about prediction. So you can have diagnostic studies, you can have prediction studies. So I'm essentially going to touch on prediction. We need to innovate, and that is because we need to probably find out a technique where we can predict something which is cost effective. And we know, I mean, all this I'm just going to tell you in glimpses. Preeclampsia is something that contributes to about, say, 5 to 8% of all pregnancies worldwide, but it's not the truth. This is one of the papers that I actually saw in the Public Health Foundation of India. There have been some reported annual incidences of as many as 33% in Haryana and 87.5% in Tripura. This is one of the annual incidences which is quoted, and probably this could be because of underreporting or reporting in medical colleges or collection of different kinds of data. There's a lot of disparity in collection of data in our country. So it's not exactly 5 to 8%. And most importantly, what we should understand is these are the primary risk factors that we are always looking at. We're looking at prime-eparis women, we're looking at multifetal gestation, extremes of age, previous history of preeclampsia, obesity, hypercoagulable states, lupus, long interpregnancy interval. But apart from this, we have something which is very, very unique to our country, which could be tobacco chewing, dietary consumption of eggs. There have been some incidental associations in some of the papers, socioeconomic status. Muslims are known to have had more preeclampsia in some parts of the country. Non-working women, these are all the epidemiological factors which are unique to India, where there has been contributed high incidence of preeclampsia that's reported. So we need to work with our population using the biomarkers, and can we do something predictive? But what is very, very common globally is the implications of preeclampsia is life-threatening. It could progress very rapidly, and you can have eclampsia, HELP, abruptio, and fetal manifestations like fetal growth restriction, prematurity, and ICU stay, IUFD. I mean, we were talking about all this for the last 2 days. But what are our concerns? I mean, if preeclampsia does not come with a tag, a woman doesn't say, I have preeclampsia, a woman doesn't come with a textbook definition of 140/90s, say 4 hours apart with proteinuria. So, but it is still preeclampsia, and it could be very progressive and devastating. We have atypical preeclampsia where the onset is less than 20 weeks, symptoms of preeclampsia without hypertension or proteinuria. So we don't really have clinical manifestations which typically fit the textbook definitions of preeclampsia, and that's the confusion. So just for the broader understanding, early onset preeclampsia is something that happens less than 34 weeks of gestation, and late onset preeclampsia is something that happens more than 34 weeks. We are worried about all kinds of hypertension which can probably result in adverse maternal and perinatal outcomes. Instead of probably coining preeclampsia as something that is proteinuria,